Good afternoon, everyone. I hope you guys can all hear me. It's a real pleasure to welcome you all to, this is our second National Network Education Day. We've had to adapt, like everyone else, to the pandemic, so we're kind of virtual. So I'm sorry we're a couple of minutes late starting. We've got, a really good day, I think, planned. We've got a few hours that kind of covers all the bases. I'm kind of sharing this first session with Julie Roberts, and many of you will know Julie. Julie and our mum Wilma have been kind of really key supporters of Meso in Scotland, and have been really key in developing the network to a funded position, and also helped us develop QPIs, and have really been a supporter of our research programme as well. Can I get next slide, please? In terms of the programme, you should have this. It's a wee bit blurry on my screen. I don't know if you guys can see that, but really just to kind of flag up, we've got essentially 3 sessions. That's a wee bit better. The first session is really a reflection on our national network, and that's going to include obviously myself and Julie, and then Anna Morton, who's our network project manager, is going to really give us a review of the MDT's activity. Rocco Balancia, who's one of our thoracic surgeons, is going to talk us through Mars 2 and where we've got to. Phil Reid, who is the clinical lead from Lothian and a colleague chest physician, is going to tell us really just take us through some early reflections on a QPI. And then we're going to have about 15 minutes just to really for you to ask questions. So just in terms of housekeeping, this is all a bit new to all of us, but what we want you to do is to use the chat function just to ping in some questions, not in a conference kind of way at the end of the session, but really as they come to you during the talks. And we've got some staff in the background who'll field those, and we'll ping those into me, and I'll try and kind of field them, and we can try and answer some of them for you. And the other thing I should mention is that each session is sponsored, and you can see our sponsors there, which I'll come to a little bit more. Now, could I get the next slide, please? So I thought before we kind of moved forward, we would just look back a little bit. I mean, this is really, it's taken us about 10 years to get to today. It's been a kind of 10-year effort in terms of making mesothelioma a disease that's really supported by a kind of national infrastructure. And we did, start off with a kind of local pleural disease service in Glasgow, which, I think there were kind of probably, there are 7 steps there, but I think there were kind of some big themes, and I think they'll be reflected through today. And those really were the funding of our first nurse specialist, and we've got a big session on our being delivered really by and through our nurses. And also, having patients at the heart of it, and families, and that's very explicitly why Julie is talking first, and why she's going to give us her views, and also the kind of political awakening that allowed us to get the QPI through and the network funded. Can I get my next slide? So this is how the network looks in terms of its clinical staff, and the nurses are in kind of blue halos. This is the way they presented their pictures to themselves, but it's not far off the truth. Phil in Edinburgh hasn't got a nurse in his halo yet, but we have got all the other staff members funded, and you will know many of these faces, and we provide funding to most of these places, well, all of these places, but to varying amounts of these people. So we've got 2 CNSs in Inverness, and we've got Beth Sage and Carol McGregor in Inverness. And we've got Mahendran Chetty and Tracy Petrie in Aberdeen, and Phil Short and Susan Smith in Dundee, and Phil and his nursing colleague that's just about to be appointed. And then in Glasgow, we have Selena, Sim and myself, and we have two CNSs, Carolyn McRae, who's our meso CNS, and Laura McNaughton, who's our pleural CNS. And all of that is only made possible really by the support that we've had from partners, including Meso UK, Macmillan, and increasingly Clydeside Action, now Action on Asbestos, are helping with some of the nursing support. And there are some key people that are not on here that are obviously Anna Morton, who's our project manager, and Elaine Smith, who is the person who sorts out the MDT for us and will send you your outcomes nice and quickly. Can I just get the next slide? We've touched a bit on partners, and those are the key sponsors and partners of the network. I think it's also important for all our events. We can't send you out to meet the sponsors for coffee, but we are very grateful to our sponsors, and each has a session, and that's Thompson's and Digby Brown and Rocket Medical and Technical Solutions who've put together the AV package. I wanted just to finish with just a couple of very brief announcements, really. Can I just get the next slide? So the first announcement is really just that this is the Scottish Meso Network website, which you will find at scottishmesothelioma.scot.nhs.uk, and it is about to go live, and it's meant to be a central portal for patients and families to get information, and also some resources for clinicians. It's had some review from our patients and carers, and it's had some review from our professionals, and it will go live very soon. I'm not entirely sure when, but I think within the next week or so. And then if I just take my last slide, the other thing that I would like to highlight is that we have our first national virtual support group, which has been really coordinated by our CNSs, and with fantastic support from the Maggie Centre in Inverness. And so that first support group, which will run on Zoom like everything else at the moment, will happen next week. And that will obviously be a regular occurrence. So I'm going to stop talking, and I'm just going to hand over to Julie. See if that works.
Yeah, if I'm muted. Yeah, hi. I'm Julie. Actually, I was going to start by just quickly showing a picture of my dad, because I realised I didn't do that at the last session, and you might actually wonder. So if you can see, hopefully you can, this is my dad and my mum and my niece. This was New Year's Day, maybe I reckon about 8 years ago. So yeah, just a nice thing to start off with. So yeah, hi, I'm Julie. For those of you that don't know me, I was just going to start by doing a super quick recap on my sort of story and my involvement, and it is super quick. It's like 3 years condensed into like 3 minutes. In 2015, my dad and unfortunately my uncle were both diagnosed with mesothelioma, and they both died 8 months later. And when I was thinking about what to say, I was remembering that what really characterized that period in my life was this line, and it was, "Mr. Roberts, you have mesothelioma, go home and die." And that sounds crude, but that is exactly the message that I heard, and that stayed with me. It stayed with me since the day he was diagnosed. There was nothing, there was no lifeline thrown to us. The information that we were given was so sporadic and so disorganized, and nobody was really sure. It was like, oh, I think you need to go here for information, or so-and-so's doing some work on that. It was just, and it ate into all of our time that we had left with Dad, and it just made an awful situation 100 times worse. And at the same time, and forgive me for saying this because this is going to sound crude also, but I had a friend whose mum had been diagnosed with breast cancer, and they could not throw enough stuff at her. It was try this trial, go to this place. There was a clear path between A, B, and C, and I was just like, what has happened in our system that my dad has been shown a red light and this lady, who is lovely, has a green light? It just did not sit well with me, and I just didn't understand what had gone wrong, that somebody had been allowed to kind of make a decision to say that my dad's life didn't count and somebody else's did. So after Dad passed away, and once the fog had kind of cleared, I decided to kind of look into it in a little bit more detail. And actually, when I did, I was right. It wasn't fair. And where I started was the Scottish Government's cancer strategy, and they claimed to have covered all 200 known cancers at the time. This was a few years ago. Or they had covered all 200 known cancers in Scotland, and yet there was not one single mention of mesothelioma. And again, I found that really odd, because I knew we had the highest rate of it in the world, not just in the UK. But so it just did not make sense. And then I saw an opportunity through Hibernian Football Club to raise awareness of mesothelioma, and that's all I really wanted to do, was just to raise awareness of it, to help other people get to a GP faster so as they could have more time. And from there, it just kind of snowballed. It went from this video with Hibs to this 2.5-year lobby campaign, and I was really lucky to have the support of Kezia Dugdale. She was at the time the leader of the Scottish Labour Party. She really threw the light on it, and we got some lovely press coverage. And that's how I kind of have ended up in this little mix here. And that's really all I wanted to say. Collectively, the work that is happening now is going to reverse that message. So the message again that I heard was, Mr. Roberts, you have mesothelioma, go home and die. You are reversing that message to say, Mr. Roberts, you have mesothelioma, but this is what we're going to do to make sure that you survive for as long as you can, and if possible, never die. And no government should get to decide who lives and who dies. We're all important, and we all deserve to live a long and full life. So I really hope in the not too distant future that Kevin or Anna is going to get in touch, and they're going to say, Julie, the network's happening, but you're not speaking. Actually, we're going to get Mr. Roberts to speak. Mr. Roberts was diagnosed with mesothelioma 3 years ago. He started off in the network. He's going to tell his story about how he kind of progressed through it and how he's still with us today. And last week, he's going to end by telling us that last week he gave his daughter away at her wedding, and that's why the work that you're doing matters more than you will ever know. So it's so amazing to see everything that's happening, and I'm so excited to listen to all the speakers today. So I know a lot of you will put your coats on and go to work every day and think, I'm just going to do my job, but believe me when I tell you that what you're doing is more than just a job. So thank you so much, and it's great to be involved. Back to you, Kevin.
Unmute, the dreaded unmute. Thanks, Julie. That was great, as always. I think it's really important that we kind of remember why we're doing it. And Julie always does that very well. I think today will be a mixture of reflections on what we could do better, but also, some really positive things. I think there is just a highlight in terms of the programme. There is a coffee break, which is a coffee break or a tea break or a comfort break. But there will be a video there from Mick May, which is an interview with him. He's a meso patient, and he will tell you a story of a journey through a series of trials and how that can be. And I think that is worth tuning into with your cup of tea. So we're going to just crack on with this first session, which is sponsored by Thompson's. The first talk is going to be from Anna. So Anna Morton is our National Network Project Manager, and Anna has been kind of really critical to getting all the things working that I'd written down, like nurses in post and contracts and finances and support groups. And she's going to just give us a little bit of reflection on the NDT's activity over the last 18 months.
Hello. Hi, as Kevin said, I'm the Macmillan Scottish Mesothelioma Network Project Manager, and I'm in post for 2 years. to help support the setup of the network. Oh, sorry, I think I've gone on to mute. So basically, I wanted to start off. I'm going to look at some of the MGT activity over the last 18 months, as Kevin said, particularly looking at the MGT records. I wanted to start off with this image here from back in the day when we were allowed to actually meet in the Queen Elizabeth, which was the hub of our MGT, and everybody would dial in. And obviously now we are virtual, which has been happening since the start of the pandemic and is actually working really well. Apologies, could I speak to the IT people? I can't actually see my presentation at the full size. Oh, that's it now, thank you. So to date, we have had 73 MGTs held between, so to date we've had 73 MGTs held between the April launch and today, and we're funding sessional time from lead clinicians from 5 sites across Scotland. We have consultants who attend weekly in radiology, pathology, oncology, and cardiothoracic surgery, and also palliative care. We also have clinical nurse specialists and administrative support to support the flow of information across the MGT. So here, what I wanted to show you was the form that we actually use in the MGT. So this comes into our wonderful MGT coordinator, Elaine. And this basically contains all of the patient information, and it comes in from all the sites across the network, the spoke sites, into Elaine, who coordinates this through our central Scottish Mesothelioma MGT.net email address. So basically this form supports the audit side of things, and it supports the development of a care plan for the patient, and it supports communication across the network. So we put information in the form around the patient details, information such as exposure to asbestos. We can record the pathology and the subtype, and also the diagnostic treatment to date. And the grey area down the bottom is where we record the outcome that then gets sent back to the local sites who've referred the patients in and added to the patient's care plan. And we can also record attendance across the back. So for the purpose of this presentation, I've done a review of the activity over the last 18 months, looking at the MGT records. So in terms of the benefits of the National MGT, this is based around the British Thoracic Society best practice guidelines, which recommend prompt and effective multidisciplinary decision making. And we also are keen to include patients and carers in this process. So we're very keen that whoever presents the patients at the MGT will have actually met the patients in person and will be aware of their wishes and their desires in terms of their treatment pathway. The MGT is also key in ensuring that all the mechanisms are in place to support eligible patients into clinical trials. And as I mentioned, it supports clinical audit and the KPIs. So as mesothelioma is a rare cancer, the weekly MGT also functions as a forum for continuous professional development. So what I wanted to do was look back at some of the original network outcomes from the project phase, looking at the outcomes between the project phase through 2019 to 2021. Initially, looking at diagnosis and referral, we would hope to increase the number of patients discussed at the MGT and also to speed up the time from referral to diagnosis, as well as the time from referral to treatment is also expected to decrease. Diagnosis and staging, we would hope to see that there's an increase in the number of patients in whom we have a tissue diagnosis, and include disease subtyping is also expected to increase, and also the number of patients where there's a radiological disease stage. Next slide, please. Also key to, as I mentioned, key to the MGT and to the success of the project is an increase in the access to clinical trials for patients from across the country. So we would hope to demonstrate that the number of patients offered access to clinical trials would increase across the country, and also the number of patients recruited to clinical trials is expected to increase as communication and information flows freely through the network. In terms of the legal side of things, we would hope to see a decrease in patients referred to the Procurator Fiscal for a post-mortem due to consensus diagnosis being achieved at the MDT. So in the last 18 months, from April 2019, when the MDT was launched, right through to September 2020, there has been 447 referrals in total to the MDT. And based on an analysis of the records in the first year of activity, from the 12th of the 4th to the 3rd of the 4th, 2020, we have had patients referred from 25 hospitals across the network, and there's been 331 case discussions. 89% of those patients were male, which is in line with the national average and what we'd expect, and the median age was 74 years. 63% of patients described asbestos exposure, which was recorded on the MDT record, as I pointed out earlier. 181 out of 223 patients were diagnosed with mesothelioma, and we had performance status recorded in 94% of cases. Next slide, please. So we can also see that we had 203 out of 223 patients, 91% had a histological sampling, and also that standard histology was recorded, including the following subtyping: epithelioid, biphasic, sarcomatoid, desmoplastic, and undifferentiated. So the disease stage was recorded in 87% of patients. Next slide, please. So we can see here, of the 110 patients diagnosed between April 2019 and December 2019, we are able to record the subtype for those patients, with the main diagnosis being epithelioid mesothelioma and the second diagnosis sarcomatoid. 88% of patients diagnosed during this time were male and 12% female, and Steph will go in session 2, Steph will go into more detail in her research on gender in mesothelioma. Next slide, please. Again, if we look at the diagnosis this year, between January and September 2020, there was 90 newly diagnosed patients following a similar pattern. Next slide, please. 89% of patients diagnosed between January and August were male, and 11% female. So one of the key recommendations in the BTS guidelines, best practice recommendations, is that all suitable patients should be offered access to a range of clinical trials, particularly those involving surgery and new drug treatments. So we can see in 2019 that clinical trial recommendations for 84 out of 181 patients included MARS-2, Confirm, Atomic Meso, Infinite Systems 2, Trizell, and Mesotrap. And 26 out of 84 patients were recruited to MARS-2, which was the most frequently recruited trial, and Rocco Balancia will discuss that in more detail in his session. So in January to September 2020, there were 48 out of 90, 53% of patients recommended for similar trials. Recruitment to trials was suspended for 3 months during the first wave of the pandemic. So to date, we have 5 patients consented to trial in 2020. I've recorded here some of the reasons why patients may not take up the offer of the trial. Some of these around distance of travel. So, for example, if patients are in the north of Scotland, they may not want to travel to Glasgow. Some patients who are asymptomatic want to maintain a watchful waiting approach, and some of the patients that are sent forward for review are not fit for trial due to comorbidity. Next slide, please. So in terms of palliative care and best supportive care, the best practice BTS guidelines recommend that all patients with difficult pain should have access to palliative radiotherapy and specialist palliative care. So in 2019, there were 36 palliative care best supportive care recommendations, and a palliative care specialist was present for 74% of MDT meetings, facilitating palliative care referrals for 23% of patients. In terms of postmortems, between April and the last 18 months, there have been 36 postmortem recommendations, and to date, 16 have been carried out and 6 confirmed cases of mesothelioma. So as I mentioned, we'd hope to see a decrease in the number of patients being referred through consensus diagnosis at the MDT. In terms of case ascertainment, there was, in the last 18 months, there's only been 12 cases of potential confirmed mesothelioma not discussed at the Scottish MDT. So as part of the QPI process and the ongoing sort of auditing of the MDT records, we'll be looking at the reasons why these patients might not have been referred and looking at appropriate action plans around communication with local sites. So just to finish up, I wanted to look at to date, the Scottish mesothelioma pathway has not been audited, and at the moment, we've got the first QPI interim report, which Phil will be talking about, and we're also gathering the data to feed into the national MDT, which Mesothelioma UK, the national audit report, which Mesothelioma UK fund with the Royal College of Physicians. So just as a comparison of our first year of data from April to April 2020, based around the audit standards from the National Mesothelioma Audit Report, we can see that each of the areas, performance status, the stage completeness, the MDT discussion, the pathological confirmation, and the staging, we can see how our MDT has performed to date. So all of these, the audit standard is 90% in each of these areas, and the areas in the blue box represent the last mesothelioma audit report in 2018 based on data from 2004 to 2016. So we can see the Scottish Mesothelioma Network in year one, the performance status completeness is 94%, stage completeness 87%, MDT discussion 94%, and pathological confirmation 91%, and pathological subtyping 97%. So we can see from that the MDT to date is performing well against the national audit standards. So in terms of what next, our key objectives are to ensure equitable access to an ongoing basis to a broad portfolio of clinical trials. We're also going to be taking part in the West of Scotland Cancer MDT improvement work, looking at the technology for our MDT, building on the virtual platform that we have now, and making sure that our communication flows as quickly as possible in terms of the technological support. We're going to carry on with the auditing of MDT records based around feeding into the QPI report, the final QPI report, and first, which will be available next year, and also the National Mesothelioma Audit Report in 2021, and also looking at our project objectives. And finally, we would hope to demonstrate a reduction in post-mortems through the consensus diagnosis achieved at the MDT. Thank you very much.
Okay, thanks, Anna. So that was a kind of very comprehensive look at the MDT. I'm sure people might have their own experiences of the MDT, and we are very keen to hear from you and learn. And if you do have any points you want to make about the MDT, please do put them in the chat function. I'm going to just introduce now Rocco Balancia. So Rocco is one of our mesothelioma surgeons. So Rocco's based in the Golden Jubilee and has been a huge advocate for mesothelioma in Scotland, and a hugely important member of the MDT, and he's going to give us an update on Mars 2, which is obviously nearly finished. But Rocco, I'll hand over to you. Rocco, I think you'll need to unmute. There you go.
Yep, can you hear me now?
Yep.
And I cannot see my slides. Okay, so yes, thank you, Kevin. Thank you, Hannah, for organizing this, and thank you, everyone, to be here. First of all, I would like to thank you, the other two people that were that made Mars 2 possible in Scotland. They are Clinton Ali at the Bitson Hospital from the oncology side, and Alan Kirk, of course, here from the Golden Jubilee Hospital. The Mars 2 trial is the one of the most important trials in mesothelioma, trying to give hope of a cure or prolonged survival to patients. We still don't know the answer as to whether surgery is beneficial or not to these patients, and this trial is specifically looking at comparing chemotherapy and surgery versus chemotherapy only. The outcomes that we will be looking at are, of course, survival, first of all, but also quality of life and cost effectiveness. Next slide, please. This is how we've sort of set up the algorithm where we discuss patients at our MDT, and we of course review the baseline CT scans. We provide staging, and we ask ourselves whether the patients are resectable. And then next slide, please. Of course, if the patient, if macroscopically complete resection can be achievable, next slide, then we decide to go for, sorry, I'm having a problem with slides and everything. It's not responding. Right. Okay. Once we define if the disease is potentially resectable, we might then want to refine that decision by performing magnetic resonance imaging to exclude any multiple foci of chest wall invasion or diaphragmatic or transdiaphragmatic invasion, and then patients will have a PET scan before being enrolled in the trial to exclude extra thoracic disease. In parallel, we are obviously referring the patients to local oncology, so that's where they're first seen, and then they're screened by a Mars 2 surgeon, and then eventually by a Mars 2 oncology at the Bitson, and then they are enrolled in the trial, and the trial design is of 2 cycles of chemotherapy up front, and then at the end of these 2 cycles, clinical and radiological assessment again with CT, and then randomization to either surgery in the form of extended pleurectomy and decortication, and after that further chemotherapy, or no surgery and straight to completion of chemotherapy. We've included basically all possible completely resectable disease with no restriction on histology. So fitness was also, of course, one of the important criteria, and we would usually look for patients that would be fit for a lobectomy. We've also included patients with potential intrathoracic but resectable nodal disease. Of course, this is a lung encased by mesothelioma, and the aim of the surgery, the way we do the surgery is, of course, there's a large thoracotomy. We peel off the parietal pleura from the inside of the chest wall, and then we do the same with the visceral pleura from the surface of the lung. And with regard to diaphragm in red and pericardium, for infiltration is quite common, and therefore we tend to resect, and that's where the name extended pleurectomy and decortication comes from, the pericardium and the diaphragm as well, and we reconstruct them with patches. This is just a chest X-ray image of a patient before and after an EPD. And the question from actually came for Mars 2, actually came from Mars 1 study, where extrapleural pneumonectomy was compared in a multimodal setting to non-surgical treatments, and you can clearly see from the two different curves why it was stopped in the feasibility study because of the significantly worse outcome in the EPP group. The difference between EPP and EPD is quite clear in this picture, where you can see that basically in the extended pleurectomy and decortication, the lung is left in place, whereas in the extrapleural pneumonectomy, it is removed. Whereas the MARS-1 trial was stopped after about 50 patients received either treatment in either arm, the MARS-2 trial has instead been ahead of the accrual, projected accrual curve, and is heading towards the completion of accrual at the end of this year. And I don't know if you can see the slide well, but the target, the predicted target was of 328 patients, and we are now just 3 patients short. They're really pushing for completing the trial by the end of the year, with a date extended now to the 31st of December. And we will be, of course, treating patients. All patients that are screened will have the ability to be recruited into MARS-2 even beyond closure of the trial. And you can see, as a Glasgow team, the beat stands quite high, and if you look at the randomization per month, so when we started at in July 2017, from now we're one of the highest recruiting centers, only second to Barts Hospital in London. Phil, I believe, will talk to us about whether we actually hit the target in terms of recruiting patients to trial, and in particular to surgical trials. So I'll skip this one. And my next one is just to give an overview of what we've actually done in this almost 3 years, or just a bit more than 3 years, where we screened from the surgical point of view about 45 patients, of which 22 were not enrolled for a number of reasons. And I think that really reflects how we were able, I think, as a team to work together to convey equipoise and enable patients to make the right choice for themselves and their families, and 23 patients were instead enrolled, of which 11 were randomized and had surgery, and 12 did not have surgery. Next slide, please. The trial, the results are expected to come out in 2022, and of course the open question is what to do next with patients that might be eligible to multimodality treatment as per MARS-2 protocol. But of course, with the MARS-2 trial not being available, what is going to happen to these patients? That's an open question, open for discussion. Of course, we know atomic Viso is, I'm hoping, a promising possibility for patients with sarcomatoid or biphasic histology. Of course, as with surgical trials, we still have Mesothelioma open. It was stopped as well for due to the coronavirus pandemic, but it's reopened again and available. And we're talking about patients with entrapped lung that could be randomized to partial pleurectomy or VATS partial pleurectomy or IPC. And of course, for the rest of the patients, which are the probably the majority of patients with epithelial disease, possibly young and fit, non-negative disease, and low volume disease. Again, there is a huge open question on what to do, waiting for MARS-2 trial results. And that's me.
Fantastic, Rocco. I think MARS-2 has been a kind of, it's been a real exemplar project for the MDT. I think we've been able to kind of offer that to patients genuinely from all across the country. And I think it's been a real kind of, really good example of what trials can offer when you deliver them across this sort of platform. Hopefully we'll get some questions in about MARS-2, and maybe there's some interesting discussions to be had, certainly. That we all hope that whatever the result, that we've got a clearer way forward in terms of mesosurgery. Now we're going to move on. We're a little bit behind time, but we can eat into Q&A a little bit. So you haven't overburdened us with questions yet, so we've got time for Phil. But please do get some questions in. I'm going to stop talking and hand over to Phil, who is our lead in Lothian, who's going to talk to us about his kind of early reflections on the MDT data, the QPI data, sorry.
Yeah, thanks, Kevin. Let me just test my clicker first of all. Yeah, that works. Good. Okay, this is a brief introduction to the QPI process prior to then reviewing the first 6 months of data that we have. Many of you will be very familiar and experts even with the process, and where there's also some people that will be joining that are less familiar. And certainly this was my first hands-on experience in QPIs. So Better Cancer Care in 2008 included a commitment to develop a programme to define how we take forward quality indicators for cancer services, and the Scottish Cancer Task Force established the national quality steering groups to develop QPIs for each cancer group. So for each cancer group, there's usually about 10 to 15 indicators that are reported on annually, and this is mandatory for each NHS health board. And the QPIs are developed between the three cancer networks, Information Service Division and Healthcare Improvement Scotland. It's important to point out that this is the first time that mesothelioma has been subject to formal national audit, and has always really been tagged alongside lung cancer services. So this is the first new tumour group, I think, to be included since the introduction of the QPI process, and it's, I understand, the 19th tumour group to be added in. So we all know what makes up the components of good cancer care, and could all speak at length, I'm sure, on what would equate to excellent mesothelioma care, but transforming that into indicator was really quite difficult. Of course, it has to be clinically important and based on solid evidence-based medicine, and that's perhaps the easiest bit. But what we found developing these, the more challenging is that it's got to be measurable, and that's definitely the more challenging aspect of this. If you can achieve these three, then you have targets that activity across NHS health boards can be focused on these areas. Improving patient survival, improving patient experience, reducing variance, and ensuring safe patient-centred care. So this process all started back in May 2018. We had the launch meeting in May, and that was chaired by Dr. Hilary Dobson. We had clinical representation from all three cancer networks present across multiple specialties and disciplines with radiology, pathology, surgeons, palliative care, respiratory physicians, our cancer nurse specialists, and of course patient representation also. 2 months prior to this, we had the BTS publish guidelines on the investigation and the management of malignant pleural mesothelioma, and this evidence base would provide the foundation of the QPIs. We also had focused groups making use of the multi-specialty approach to develop each QPI. So radiology fine-tuned the QPIs on imaging, oncology focusing on the treatment side of things, and respiratory, the definitive pleural management. There was then wide clinical and public engagement exercise, which followed with all comments reviewed, again as a group, with the QPIs finalised before publication. Again, for anyone not familiar with QPIs, this is a typical layout. So you have the short title that everyone will refer it as, and then the longer title and the description. And then a brief overview of the evidence base and the rationale for why it's important, and the measurability specifications, which highlight how the indicator is going to be measured in practice. Finally, there's the target that each unit should aim to meet, and this is often the most difficult part. and the part that needs to be kept under regular review. And review is important. A baseline review, which is where we are just now, after around the first year, to refine the measurement. You can't make any major adjustments. That's more a formal review after year 3, when you can make more significant amendments or remove QPIs or add new QPIs where there's a gap. And the sort of things that will trigger review will be any significant change in clinical practice that arises, publication of new evidence, or maybe where the QPI is consistently met across the board and not really differentiating in care. So don't need to look too much at that one. I think that's been covered by Anna. So these are the QPIs. And there's 8 in total with some subsets, and we'll just have a brief look at some of them. This is radiology 1 diagnostic imaging, and it's really designed to make sure that people with mesothelioma have the ideal CT for pleural enhancement to aid diagnosis of malignant pleural disease and staging. There's some tolerance there, obviously, to allow for poor renal function, allergy to contrast, or in some cases where it's inappropriate for further imaging. And through this process, we have identified some variability in protocols across the different sites. Second QPI, they're really just commenting on where staging is carried out with the appropriate CT scan at MDT. Our next QPI was based on histopathology. And the first bit is the proportion of patients who come to the mesothelial MDT and have a histopathological diagnosis. And it's roughly meeting the target and quite high. And I think that we talked about case ascertainment there a wee bit earlier. And I think that probably reflects why it's quite high. In that I think the people that we do miss from the meso-MDT or who are not referred are the ones that have just a radiological suspicion or not fit for further investigation. The next subset of that, which was important to ensure we're meeting, was that subtype is identified. Because that obviously has important prognostic implications, treatment indications, and an entry into trials. And then the final is when the full immunohistochemistry markers are undertaken. And all QPI 2 shows is that our pathologists do a good job with ever decreasing sample size, they will tell us. QPI 3 is on whether patients with mesothelioma are discussed at the national MDT, which we've already discussed again about, and a little bit about case ascertainment, for which there's still work ongoing. We do identify there are some regions that are low or never referrals. Some of the areas are quite complicated. Scan, for example, is 6 geographically distant hospitals from the borders to Dumfries to Fife, and have 5 or 6 separate lung MDTs serving them. So the next one is on systemic anti-cancer treatment. And you can see there's quite a lot of variability amongst the regions, but I think that's a reflection partly on low numbers here, but that same problem allows us to delve into each case individually, and we have done that for each of these QPIs due to the numbers, and we've been able to see that all care is entirely appropriate. As has been mentioned before, watch and wait is a common approach in mesothelioma, more than most cancers where the disease is advanced, certainly. But alongside this, it was identified there was deteriorating performance status from the time of MDT into current illness, and frequently, given the average age of the patient with this cancer, there's significant comorbidities that can be there despite the presence of a good performance status, so vascular history and renal impairment and these sort of things that get in the way of systemic anti-cancer therapy. And this was a difficult QPI. So what our aim here was really to ensure that radiotherapy was given for the correct indications. And it's difficult to probably read too much into this QPI as things stand. We know that chest wall pain doesn't mean that the patient has to immediately be referred for radiotherapy. And when we review the cases again, we're seeing that management's entirely appropriate with good supportive therapies and palliative care, achieving control of these symptoms in the majority. So one of the reviews of this QPI is that this QPI will likely be reported a year in arrears so that we can assess the use of radiotherapy across a longer period of time in the patient journey. And again, this pleural fluid management, this is again a difficult one to measure, we've found. Again, what our aim here was to ensure that patients across the country have equitable access to definitive pleural management, whether that be talc, pleurodesis, or indwelling pleural catheter. One of the difficulties sometimes with auditing this is that you can be symptomatic and you can have a pleural effusion, but the two may not relate, and an intervention is often not appropriate in the latter stages of life. So from here, we're going to make sure we're kind of documenting and auditing the choice of pleural fluid procedure in addition, just to make sure that there's a range that's being offered to the patients as patient choice really is crucial here and very difficult to record. So this is a clinical trial and access to research studies, and it looks quite low in this slide, certainly just over the 6-month period. And as has been touched on a couple of the talks so far, travel seems to be the major barrier to this. Certainly a lot more people who enroll in the trials are offered trials, and again, by looking into the cases on an individual basis, there was at least a further 3 in Lothian and 7 in Greater Glasgow and Clyde that were offered entry to the trials, but declined for differing reasons, although, as we say, travel is a major one. And the last KPI is looking at post-mortem examination. That's to ensure that the distress of an unnecessary post-mortem in patients with pathologically proven mesothelioma is avoided. There's a leeway of less than 10% target, and that's to allow for anyone who may have a post-mortem for alternative reasons other than the mesothelioma diagnosis. So some of the reflections after the first review of our QPIs, where we can look at the data set and the measurability. I think I've touched on most of these during the talk. So the document of pleural procedure or procedures, deferring the reporting of radiotherapy, and in QPI 2 and histopathology, the addition of other mesothelioma subtypes rather than the big 2 or 3 for the rarer histology. We've mentioned about the difficulty in measurability of these indicators, and that was certainly true in palliative care outcomes, which we all obviously recognise as crucial in the management of mesothelioma patients, but at this point in time we've found difficult to incorporate into a measurable QPI. And general reflections on the process as a whole. There's been excellent clinical and managerial leadership throughout, an excellent use of resources with the subgroup development and real open lines of communication as a group throughout, initially in the face-to-face meetings before being forced into further Teams meetings and constant email trails. Audit staff have, of course, been critical to the whole process and its success, and everyone's aware that it's early days in the network and with these QPIs, and that our work is not done, and clinical teams will continue to be fully engaged in reviewing the process over the coming years. Thank you.
Thanks, Phil. That was great. Yeah, I mean, I think it's important we look at the QPI data. I think as Phil's kind of highlighted, it's very early days with them, and some of them, the numbers are really small. But it's been really useful to think about whether the variance that we see in some of the endpoints is actually real, or whether it's low numbers. But it does, the examination of that variance is absolutely critical in us understanding how we can improve services across the piece. Now we've kind of ran over a little bit, so I'd say we have got some questions, but they're not exhaustive. So I think what we could do is answer most of them, because they're kind of some themes. The first request was to minimise my head, which I can share. That's good. I kind of accept that. And then there was a request for some slides, which we can share. There was Malcolm Will from Lothian, I think, had asked about case ascertainment and what proportion of cases of meso cases in Scotland do we think are captured by the national NDT. I might throw that one to Phil. I kind of have a thought on it, but I don't know what you think, Phil.
Yeah, I think Anna had the figures for that. I can't remember exactly what it was. It's certainly something that we are continuing to work on through a variety of routes. For example, in SCAN, I get sent the lung cancer MDT reports for the different regions, so I can check and make sure that there's not people missed there. I also get sent the pathology reports for anyone who's had pathological analysis of a diagnostic or suspicious of mesothelioma, so we can chase that up. So there are methods in place to make sure that we do try and capture those ones, because we know that probably the ones that we're missing are maybe more likely the ones that are best supportive care or don't have diagnostic tissue.
Yeah, I agree with that, Phil. I think there is an issue that patients, as Phil says, who maybe the parent teams don't think they are going to be for anything, or maybe a biopsy hasn't been pursued, that I think we would like to see, just to, if nothing else, just to connect them with the information that's available and the support infrastructure. And as the pathology diagnostics improve, which we're seeing all the time, it may well be increasingly possible to make a diagnosis with small biopsies, or which opens up compensation maybe for patients who are not fit for surgery or chemo. So we had a couple of comments about trials, which is probably the other question to touch on, and how the trials data feeds into QPIs. Rocco, you had posted a question about whether chemo is captured if it's given within a first-line trial.
Yeah, correct.
I don't think it is, Phil. I think that. Do you want to comment on that, Phil?
No, I unless any of the audit team correct me, I don't think it is either. I think it's for palliative systemic cancer therapy out with the MARS. Certainly. I don't know about the other trials actually.
Yeah, I mean the other question that's been raised. So Nicola Steele was one of our oncologists, and there's been some comments and feedback from Carol Marshall, who's one of our audit staff, is really highlighting that we as a group know that there are more patients that went into trials than you can see in that QPI figure. And I think there is an issue with, Nicola's highlighted that only maybe first line trials go in, which is obviously an issue if it's a second line study. And also I think there's an issue that the data, they don't link across particularly well. So one of the early reflections I think is that we need to capture that a little bit better. Rocco, did you think that the MARS2 numbers looked right for when you'd seen the QPI data?
No, I didn't. No, I had the same impression.
Yeah. So, I mean, it's a really important kind of thing to reflect on, and maybe because it's not just a meso thing; it's an all cancers thing that we probably need to do better.
I don't know if Mesobank would be part of the research trials, although it's not a treatment trial, of course. But certainly, if that should be counted, then the numbers are definitely lower than that I'm expecting them to be.
Yeah, yeah. So one last question just before we sign off and let you have your coffee with Mick May's video interview is Sarah Morgan, who's setting up a similar network to our own in Wales, had asked about how we cope with patient inclusion into trials with big travel distances. So I think that is a big issue. For some of the trials, it's a bigger issue than others. I think probably had, I mean, Rocco can maybe comment on this, but I think we've had a little bit of success. I can think of a couple of patients who've come from Inverness for MARS2, but I think atomic meso has been difficult because it's twice weekly visits for chemotherapy and.
Can I make a comment though?
Yeah.
Kevin, because we actually noted this, and Clinton Ali also texted me to comment on the same thing. I've actually noticed that the west of Scotland seems to be doing worse compared to other areas, and therefore that sounds a little bit counterintuitive to what we're expecting. So we would expect access to trials be higher in the central belt area.
Yeah, no, I think part of it is I'm not sure the data is very accurate around the trials. I think we're missing quite a lot. But I do think we need to look at it very carefully because the travel thing is not really sorted. I think Meso UK provides some travel grants. Is that right, Anna? Anna, maybe not entirely sure. I think it covers just visits to the trial visit, but not necessarily not sure if it's accommodation at site.
Again, I think that's on a kind of per case basis, but there are grants available.
Yeah. So I think if we're going to maximise the opportunities for patients, we do need to try and overcome those difficulties around travel. Okay, I'm going to try and bring it to a close. We're kind of 7 minutes over, and we've obviously got another 2 sessions to go, and I'm sure we can pick up some of these themes in the other sessions. What's going to happen now is I'm obviously going to say thank you to the presenters and our sponsors again, and we're going to your videos, your feed will still run, but you'll actually launch into a video interview between Mick May, who's had a very positive experience through clinical trials, being interviewed by Lorraine Creech from Meso UK. You're going to hear from Lorraine later. And so go and have a cup of tea and then come back, and then we'll aim to reconvene. So it'll be just before 2:20.
Mesothelioma in 2013. And following this life-changing event, what did he do? He went fishing. Mick's inspiring story is amazing, and his autobiography, Cancer and Pisces, outlines the journey that he has had since his diagnosis and through his treatment, intermingled with his love and joy of fishing. Welcome, Mick. How are you?
I'm very well, thank you very much. Very well.
Good. Good to hear. Good to hear. Can you tell us what it was like to be diagnosed with mesothelioma and how it affected you and the family? Big question now.
Yeah, it's a big question. Well, the simple answer is, and I'm sure fellow sufferers will understand this, one day you're normal, and the next day you're not normal. You're a rarity, and you're going to die. And I don't really know why that last sentence should be so shattering, because we all know we're going to die, but you come away with the clear impression you're going to die in a relatively small number of months. And I've always thought of that as sort of 12 to 15 months, unfortunately. So it's earth-shattering. It's completely earth-shattering. But throughout it all, I would say I've been very lucky.
Mm-hmm. And the family at that time, how I know the kids are big kids now, but they were fairly young then, weren't they? And that must have been very difficult. The 6 of them, 6 lovely children.
Yes. Yeah. Well, we're very lucky. We've got 6. I always say we've got 1 plan, 5 mistakes. The youngest was only 10. And funny enough, she was in a way the most shielded, because I don't think she knew how to use the internet, and, it was just accepted. I think it was hardest on some of the elder ones in their late teens, who, in spite of being told not to use the internet, did use the internet. And so that was a shattering event for them, because their father, who sort of, quite a character and sort of quite fit and healthy, was suddenly not fit and healthy. So, and I've never found out how it affected me. It clearly did.
And your treatment history is really quite amazing. Can you describe that to us?
Well, that's why I say I was incredibly lucky, because I think I was just in the right place, in the right time, to get the best treatment available. So I've had surgery, what was called a radical plurectomy and decortication. I know roughly what that involves, but don't ask me to explain it. I then did a line of chemotherapy with that horrid drug cisplatin, which my fellow sufferers will know well and loathe equally in the way that I loathe it. And those two together gave me about 2 to 2.5 years of remission. And then it came back, and then I did another line of chemotherapy, this time with carboplatin, which I think, if I made a plea to oncologists, it would be prescribe carboplatin rather than cisplatin. And then I went on a drugs trial in Lille for a drug called nivolumab. I did that for about 15 months. Then I had a gap, and then I had a 3rd line of chemotherapy. And I've forgotten the name of that drug, but it'll come back to me if you want it. But that was much more benign than the carboplatin or cisplatin. And then, by a bizarre, and then I started having targeted treatment, targeted therapy, as a result of having a look at my genome, and as a result of the brilliance of my 2 oncologists, one of whom you know very well, which is Dean Fennell, and the other one is Sanjay Popat, who operates down in the mast. So I have a genetic mutation which is very common in a form of skin cancer called basal cell carcinomas, and is incredibly rare in lung cancers. And I'm not sure they've seen it in someone with mesothelioma before. So I was put on a drug called vismodegib, which I've taken now for 2 years, almost to the day.
Mm-hmm.
And that has had a very dramatic effect on the size of my tumor and the way in which it's grown, and on my hairstyle, which you might like.
Oh, lovely. Yes, yes.
Which various people during lockdown looked at with great envy.
Yes, I can imagine.
So that's my sort of passage through it all.
Mm-hmm.
And I'm, as I've said, this is the third time I said it, I've been very fortunate. I've been in the right place, in the right time, with the right mutation, and so on and so forth. And I know it.
Mm-hmm. For me as a nurse, when I'm speaking to people, I'm often saying for people like you, we need the right treatment at the right time for the right person. And it's so important that we bring those things together, and also that you see people that can help you at those points. So I think your example, if we can call you an example, is spot on for how we need to move forward with mesothelioma.
Well, let's hope that people like I, and there are a number of others who've been fortunate enough to dodge the bullet for a number of years now. Hopefully, we will provide the bits of the jigsaw that will one day lead to a cure for this disease. Because it's the bits of the jigsaw that will make the difference. I'm sure of that.
Yeah.
What's amazing to me is that a number of the treatments that I have benefited from were sort of in the test tube when I was diagnosed. And that, I think, should give us all hope.
Yeah. So it's from bench to bedside, isn't it, really? It's
Yeah.
Yeah.
I mean, I remember I have a brilliant and legendary surgeon who is a great friend now. And he told me about immunotherapy 7 years ago, but he didn't describe it as immunotherapy. And it was only about 3 or 4 years afterwards that I worked out that what he was talking about was in fact immunotherapy. And now immunotherapy is more or less standard. And I hope that in 2 or 3 years' time, the sort of targeted therapies I've had as a result of having a look at your genome will also be much more standard.
Brilliant.
Hi there, welcome back. Thank you so much to Mickey and Louise for sharing the interview with us, and I hope you've all managed to take a quick cup of tea. For those of you who don't know me, my name is Carolyn McVeigh. I'm the Mesothelioma CNS based in Glasgow and the CNS in Scotland. The next session today focuses on 3 recent surveys that have been conducted across the UK, and thank you to Rocket Medical for sponsoring the session, and indeed to everyone who's sponsored so far today. As before, after all 3 speakers have spoken, there will be time for questions. If you could just pop your questions on the chat from, I'll take them and put them to the panel at the end. His colleague Lorraine Creech, she's head of nursing with Mesothelioma UK, and she's going to speak about the Mesothelioma Outcomes, Research and Experience Survey, the MESO-MORE study. This is a large study looking at patient experience and covering clinical circumstance, experience of care and quality of life. Thank you so much, Lorraine, for agreeing to speak to us today.
Thank you. Thank you for inviting me to speak about the MORE survey. Just a little bit forward on my clicker there. So thank you for inviting me. I hope that you find this informative today, talking about the Mesothelioma Outcomes Research Experience Survey. Reposition myself to see the slides, which are rather small for me. I'm going to pass through this slide because this is really just an update on Mesothelioma UK. So as you can see, the MORE survey was a survey conducted in the first half actually of 2019. So that was completing around about the summer of last year and took us some time to report on. It was Mesothelioma UK's second large-scale survey, really comprehensively capturing real-world experience of patients from diagnosis and through treatment and care. Moving on then. The questionnaire was divided into 3 sections, as you can see. One was the patient experience of care and treatment. Secondly was a quality of life assessment tool, which was the EQ5DL. And thirdly, the individual clinical management of mesothelioma. Now, the survey was registered with each NHS trust via the mesothelioma nurse with the clinical audit department in that trust. And patients were able to access the survey via a tablet, via a web mesothelioma website, or in a paper survey. The clinical management survey, which was section 3, had to be validated by a CNS, and all the data was anonymous. So this is just a picture to show you where the 28 nurses we have to date are based across the UK. Very much in a hub and spoke across Wales, but I'm very glad to say that we now have a hub and spoke across Scotland, and 2 posts are awaiting in recruitment for Essex and Edinburgh. So the patients were recruited, and I do want to stress it is a survey, and they learnt about the MORE survey from other patients, from the CNS, from support groups, from asbestos support groups, and from Mesothelioma UK via social media. Now, we had in total 503 responders. We actually had more responders than that, but we could only validate 503. And I'm very glad to say that of those numbers, there was 32 Scottish responders. I just want to make clear as we embark on the results that this was a survey, so it's not like the hard and fast data that we've been delivered from Phil and Rocco and Anna. So it is a survey answered by the patients, and it's the patient's responses. So as you can see here that we had 289 patients who were over 70 in the whole of the survey, and in Scotland was 19 of those patients. Also, this was by gender. Of the 32, 2 were female and 30 were male. As you can see here, there's no surprises here in the number of patients by site of diagnosis with left pleural and right pleural, the right pleural being slightly larger number, 2 peritoneal and 1 who did not identify the site of disease. Looking here, you can see the slides are very, very small for me, guys. In the events team, so I'm just relying on paper copies next to me as well. But as you can see on tissue diagnosis, that we had 84% of Scottish patients had epithelioid, 3% were sarcomatoid, and 13% were unspecified. Now, this only really differed with the national data. In the national data, we did have some mixed and biphasic patients. Clicker's gone to sleep on me here. If you see there, that's great. Thank you very much, guys. That's much better for me. This slide just shows the complexity of the number of investigations that were undertaken and what the patients go through to actually get through what we hope will be a tissue diagnosis. So we looked at occupation and we looked at the exposure. In Scotland, we had 2 electricians, 3 engineers, 4 carpenters, 1 lagger and 1 plumber. And interestingly, in Scotland, we had 1 teacher. Sadly, 8 patients left this survey blank and 8 patients reported being of other professions. So it did leave a little bit of a gap there in occupation and exposure. Now moving on to the data that we had, which we class this as real world data because it is obviously from the patients. And on these slides, you will see the national data alongside the local data for Scotland. So we looked at patients who had attended the GP 5 or more times before referral, and that was 2 of the responders in Scotland. We looked at those who had attended hospital 20 or more times over the last year, and that was 6 of the 31 responders in Scotland. Those who'd been admitted to hospital 5 times or more in the last year was 2, and those who had had more than 3 CT scans in the last year was, as you can see, 13. So moving on, we looked at managing the symptoms. 18 of the 31 responders had experienced pain. So 58% experienced pain, 53% experienced breathlessness, 61% experienced fatigue, and 58% experienced cough. Now, this slide shows the experience and how the patients identified their experience in what had been done for them to help them in as much as possibly could by their doctors and nurses. So these results are based on those patients who answered yes, and yes, they did to some extent. So 94% thought that their doctor and their nurse had done everything they could do to help with pain. 88% thought that everything had been done to help with breathlessness, 74% everything to be done regarding fatigue, and 56% everything that could be done regarding cough. Not understandably, with cough being the more difficult symptom, perhaps, as we would say, to help with. So moving on to managing the pleural symptoms. Again, of those patients that answered this question, 24% had had pleural fluid drained more than 5 times. 50% were offered an indwelling drain, and 19% actually had an indwelling drain. Moving on to look at communication and support. 25% felt that they had been told their diagnosis in a way where it could have been delivered more sensitively. 6% had received some support regarding end-of-life planning, and 19% had received information regarding the role of the Procurator Fiscal. Moving on to treatment, 66% of responders had had chemotherapy, 6% of responders had had immunotherapy, 6% of responders had had radiotherapy, and none of the responders had undergone 3 lines of systemic treatment. Looking at surgery, as I said, remember this is a survey very much at odds, I think, with Rocco's data earlier. Those who had had surgery were 3 of the 32 responders, which accounted for 9%. And those who had had a surgical biopsy were 14 of the responders, which accounted for 44%. This is just another slide to show the amount of and the way that the treatment had been given. And you can see that 3 had not had any treatment at all. Moving on to trials, which was very interesting, reflecting on our earlier sessions. Of those that had had clinical trials discussed with them, 38% had had clinical trials discussed at the time of diagnosis, 16% had had trials discussed during their treatment, and of those that had been enrolled in a clinical trial was 28%. So, bringing some of these to conclusions, I think we can see that Scottish patients had less visits, being at 19% versus 26% of the national cohort, and less CT scans at 41% versus 64%. 24% of Scottish patients had had fluid drained 5 times or more versus 16% in the national cohort. However, 50% were offered an interpleural drain versus 31% nationally, and 19% versus 13% had actually had an interpleural drain. 25% of patients felt their diagnosis could have been delivered more sensitively. Perhaps a reflection back to what Julie was saying earlier, but I think we've massively moved on from then. Regarding treatment in Scotland, 66% had chemo versus 76% on the national cohort, 6% versus 11% on immunotherapy, and 6% versus 9% on radiotherapy. So very much a muchness there, I think we can say. If we're looking at surgical diagnostic procedures, 44% in Scotland versus 40% in the main cohort, in the national cohort, and resection was 9% versus 17%. Again, remember please that this is patients who took part in the survey. For Scottish patients entered into clinical trials, it was 28% versus 31% nationally. And 19% of patients were informed of the Procurator Fiscal, which was less than the 27% in the national cohort who were informed about the role of the coroner. You may want to tease out some differences there, which I've reflected back on our previous sessions earlier. And for end-of-life planning, it was 6%, or support towards end-of-life planning seemed to be given by the doctor or the nurse. It was 6% versus 9% in the national cohort. So, going forward nationally, we need to do some further work on the group analysis of the EQ5D5L. What we do want to do is take the MORE survey forward onto a digital platform. We're doing some work along the roads of this called Mesodax, and we would like that to be integrated into the National Mesothelioma Audit. So this would be where patients were consented to fill in data at a period that was fitting to them, maybe monthly, maybe 3 monthly, on their treatment, on their burden of disease, on quality of life survey. And then we would have information going forward to really monitor our patients on a very large scale. So looking at our findings from Scotland, there appeared to be less hospital visits and less CT scans within the last year. That may be good, that may be bad, very much up for discussion in the time of COVID. And I think if we'd have been doing the survey this year, obviously that question would have probably been blown out of the water. Pleural effusion management in Scotland, it seemed as if patients were more likely to have an interpleural catheter or an interpleural drain going through the cohort that we spoke of during the time. It appears that less patients in Scotland having surgery. Rocco's data obviously doesn't reflect that, and so that's an important point to establish. And I think across the board we need to improve communication and end-of-life care planning and support for our patients. Sorry, my clicker keeps timing out on me. So here now we have just an image of how we would like to take a platform forward, a digital platform where patients could actually talk about their experience and give us some hard and fast real world data to go on with and manage their care. Just leaves me thanks to give some thanks and acknowledgements to all of the Mesothelioma UK Scottish CNS team who were really helpful, to Anna Morton, who did a brilliant job of disseminating and the survey to people and those that would be able to pass the survey on. I think that's another reflection of how this network has really taken off. I'd like to thank Alicia Riley and our ops team who prepared some of these slides for me, the asbestos support groups who helped out. Dash Global and SNAP Surveys were our partners. Bayer PLC gave an initial grant to get us started, and Euroqual for allowing us to use the EQ5D5L tool, which, as I say, we need to do more reporting on. But mainly, my thanks go to the patients and their families who let this survey, the MORE survey, take part. Thank you.
Thank you, Lorraine. Thank you for presenting all the data, but also thank you to Meso UK for collecting and sorting all of the data and the team that works with you. And we really appreciate the time that was spent over the last couple of weeks to pick out all the Scottish data. I know that there's been a lot of time and effort that's gone into that for today, so thank you so much. The next session is presented by Dr. Stephanie Ejejimemi, who is a research associate at the University of Sheffield. Steph's kindly agreed to speak about the gendered experience of mesothelioma study, or GEMS. This study really explored the experience of men and women with mesothelioma and their carers and family, as well as the staff who come into contact with them, and was aimed at understanding why any differences that were identified occurred. Thank you, Steph, for coming along today.
Hello, everybody. Thank you for having me here today. It's really lovely to be here. So today I'm going to present the gendered experience of mesothelioma study. Okay, so just to begin with, I'll give you a brief project overview. So our aim was to explore men and women's experiences of mesothelioma and to understand the similarities and differences that occur across the mesothelioma pathway from the perspective of patients. So it was a mixed method study. Stage 1 was the statistical analysis of national data. Stage 2 involved qualitative interviews and analysis. And then stage 3 involved testing the findings out with key stakeholders in focus groups. Okay, so HASAG, which is an asbestos support group from the south of England, very kindly provided us with a data set with cases from 2016, 17 and 18, and we had 1,177 mesothelioma cases. As you'd expect, the majority were from men, so 83% were from men and 18% were from women. So we found a few differences in the HASAG data set. Firstly, in age. So both men and women were mostly in the 71 to 80 age group at diagnosis. But what we found was that there were more young women in the cohort. So 5% of women were under the age of 50 compared to only 0.5% of men. Another interesting difference that we found was that fewer women had a next of kin, and also fewer women had a spouse or a partner. Now, when we were looking at types of mesothelioma, again, as we'd expect, we saw the majority of cases were pleural, but we did have 1% of cases that were peritoneal. And we found that women were more likely to have peritoneal. Okay, so we also explored compensation a little bit and what people felt about that. So proportion who said they would go in to call a solicitor, and proportion who said who actually called a solicitor. So what this means is that the percentage of both men and women who are going to call a solicitor decreased over the 3 years, which surprised us. And the trend was the same for both men and women. And the number of men dropped by 12%, and for women it was 27%. So what that means is the percentage of women who seek legal advice dropped by nearly 20%. Now, so we spoke to our legal colleagues and kind of asked for some explanations of what might be going on there. And I think it's important to highlight that this is a relatively small data set. So these findings need to be tested out in a larger number of people. But yeah, we thought it was interesting. Okay, when we were looking at occupational risk, our findings were that the high-risk occupation for men was construction, carpentry, joiner, plumbers, electricians, all the things that I would say you commonly associate with asbestos exposure. But what we saw in the women was that the high-risk occupations were in administration, teaching, healthcare services. So I think it's important to highlight that we might need to look at risk, occupational risk in different ways for men and women. Okay, and then we also looked at the industrial injuries benefit. We missed out a word there. So we found that 11.6% of women did not receive the IIDB award compared to only 3% of men. And when we measured time from diagnosis to IIDB award, we found that the median time for men was shorter than for women. So women were taking longer to be awarded their award, their benefit. So now in stage 2, we interviewed 11 women and 13 men who were kind enough to participate, and we're just really grateful because Meso UK asbestos support groups were absolutely fantastic in helping us recruit to this study. So we had a range of ages. Well, we tried to get as much diversity as possible. So our age range was between 31 to 79 years of age. We had a range of living circumstances. We did manage to find 2 Scottish participants. The length of time living with mesothelioma was between 5 months to over 5 years, and we had a range of occupations. So the first key finding I'd like to talk about is that obviously a diagnosis of mesothelioma was absolutely devastating, and that always comes across in any interview that we do. But what was interesting was that men and women were both practical at diagnosis, but the way in which they enacted that practicality differed. So as you can see, Amy here, sorry, I should highlight we're using all pseudonyms. So Amy here says, you know, the first thing she did was to come home, chuck everything away, because her idea was that men don't wash net curtains. And we did see this in the women's interviews, that the domestic sphere and making sure that the family would be okay in terms of the running of the household, domestic chores, and emotional management also was taken care of. And what we saw in the men's interviews was it tended to be about financial management and the paperwork. So what Ivan did was to put all his affairs in order so that he didn't have to leave his wife with a heap of stuff to do, as he said. So control and treatment was another interesting one, particularly around treatment and trials decisions. So again, we've got Ivan there saying, I'll be telling them to stick the chemo where the sun doesn't shine. So the way in which the men spoke about their decisions was a lot more assertive and decisive, even if later on, as was the case in Ivan, they said, actually, I do want the chemo. And women tended to go for the, I'm not really sure, I'm not very good at making decisions. And it was just a very different way of expressing themselves, which, you know, as healthcare professionals, we need to be aware of. So when it came to impact on family, I've got 2 quotes from women here, because what really came across was that emotional burden, the emotional management. There Kath is saying she wasn't sure about going on a trial because she had caring commitments for her husband. And then Grace there was, you know, I'm not sure when I should ask my partner to come and visit me because I don't want to have a bad impact on his mental health, on his anxiety. And so that emotional aspect was really there in the women's accounts, whereas with the men, it was all about the financial well-being of the family. Risk perception. So although we were studying gender, there was also something about the occupations people worked in. So there you've got Fred at diagnosis. His feeling was a sense of inevitability. You know, he had friends who had asbestos related diseases, or who had died of asbestos related diseases. So at diagnosis, you know, devastating, yes, but not really a surprise. Whereas for women, especially those who hadn't worked anywhere near asbestos or had partners or husbands or fathers who had worked in asbestos industries, you know, Fiona thought, what a stupid question to be asked, because asbestos related diseases weren't even on their radar. So seeking compensation, this was another interesting one, because you've got Irene there who wasn't 100% convinced. Women seemed a bit reticent, a bit reluctant to pursue compensation, or at least the women we interviewed. So that aligned with what we found in the numbers data and the quantitative data. And then Ivan there is saying, I deserve that and I should have that. So there was definitely a sense of entitlement for the men, but that entitlement was born out of a desire to look after their family and provide for their families. Okay, so stage 3 kind of got cut short because of COVID, but we did manage to speak to a group of Meso UK nurses just to test out our findings and get their thoughts on that. We have done some dissemination. This also counts, so I'm really happy to be here. So important points from the data is that the importance of a sense of control at diagnosis may differ between men and women, and this difference may have implications for the delivery of healthcare. And women and men may have different priorities during their mesothelioma journeys. Women may lack awareness of the risk of exposure and asbestos-related diseases. The nature of exposure to asbestos may be quite different. Therefore, we need to consider occupational risk different for men and women. And women are less likely to seek compensation according to our data set. So this could be due to lower awareness amongst women and a higher sense of entitlement amongst men. So in terms of the next step, we've got a report due to launch. We've got a couple of publications that are, that we're preparing. And I think what we're doing is trying to kind of bring together quite a few studies that we're working on and develop that. So we've recently been awarded the Mesothelioma UK Research Centre. So that's due to launch on the 23rd of November, and it's going to be led by Professor Angela Todd and Dr. Claire Gardner. So our vision is to conduct a portfolio of robust and rigorous research with a reputation for excellence nationally and internationally. I've run out of time, I think, but I've just got a quick list of the projects that we're working on at the moment. So please do contact us for any research ideas. And we're running a research prioritization exercise. We really want kind of the lung cancer, the mesothelioma community to come together. That includes healthcare professionals, legal professionals, patients, carers, anybody who might be involved, to say what do you think is important to the patient and carer experience, how can we improve it, and then we're going to have a mailing list, so please do contact us if you want to be added to that mailing list. So lastly, just to say thank you for listening, and thank you to, of course, everybody who participated, to Mesothelioma UK and the others who funded us. So thank you.
Thanks, Steph. I think examining patient experience always helps to shape services and redesign, but I think this study in particular has a focus on how we act or speak to patients and the impact that we can have. So thank you so much for sharing your findings with us. I know it's given me a lot to think about, and I'm sure it will for everyone else. Finally, in this session, we've got Dr. Peter Allmark, who is also based in the University of Sheffield and is a senior research fellow there. Peter's kindly agreed to speak to us
about the MAGS study, which has only very recently been published, and this is the Healthcare Staff Mesothelioma Asbestos Guidance Study, which was really aimed at developing a critical account of the experiences of presentation, diagnosis and treatment and care for healthcare staff who have mesothelioma. Thank you, Peter, for joining us today.
Thank you very much. That's my first slide. So I'm reporting on this project, which took the acronym MAGS. You can see it's concerned with healthcare staff. I'll see if my clicker works now. I need to. No. Can I have the next slide? Okay, so I'm getting an echo at the moment. Let's stop getting an echo now. So this report, it took the acronym MAGS, and that was because it was inspired by Dr. Mags Portman. You can see the front cover of our report there, and that's Mags Portman, who was a senior and kind of pioneering doctor in the area of HIV, who died of mesothelioma aged 44. And she'd been exposed to asbestos through her work as a doctor. And the report was published a couple of weeks ago now, and there's the link to it there. Lost my internet. So next slide, please. So the aim of this project was to look at the experiences of presentation, diagnosis, treatment and care for healthcare staff with mesothelioma, and it involved sort of three main stages. One was to review the literature to see what had already been said or researched in terms of healthcare workers and their experience. A second was a freedom of information request, which I'll come on to, and the third was a semi-structured interview with a number of former healthcare workers who had developed mesothelioma. Next slide, please. So in terms of how many NHS workers develop mesothelioma, we did this because there was the data that exists at the moment is based on this mesothelioma mortality by occupation, and in that document, the number of people with the number of healthcare professionals who've developed mesothelioma or who've died of mesothelioma is quite low, and that has kind of led to a conclusion in that report there that healthcare is a relatively safe place to work, safer than average place to work. It says similar things with regard to teachers as well, as a matter of interest, and mainly sticks to the idea that mesothelioma or asbestos is mainly of risk to those working in the traditional industries, and that didn't tally with experience of people, our awareness of Mags Portman, but also of quite a number of other people who worked with mesothelioma, including legal professionals who could see that there were more. Often they had more sort of healthcare workers on their own casebook than was sort of showing up in the official statistics. So we wanted to try and get a better idea of what the actual figures might be. And to do this, so next slide, please. We put in a freedom of information request. And this was the way we did with this. people who have developed asbestos, who have developed mesothelioma due to asbestos exposure, will often take legal action. As we saw in the last presentation, about 50 or 60% of people will probably take legal action against their employers with a view to showing that they were negligently exposed to asbestos at work. So we asked the NHS Resolution, which is the body that deals with legal claims, how many current or former NHS employees had sued the NHS because they believed they had developed mesothelioma due to asbestos exposure at work. And you can see on the figures there, the sort of claims starting in 2004 and then climbing pretty steadily, with one particularly higher year in 2013-14, climbing from about 38 to last year 148. So these are all people who worked in the NHS and who have developed mesothelioma and believe that it was due to asbestos exposure at work. Now, if we can, so if we have the next slide, if you compare the data from the ONS with this data, the time figure period isn't exactly the same, but between 2002 and 15, there were 177 deaths recorded of NHS professionals in the ONS data. And at the same time, there were 961 claims made against the NHS. Not all of those were successful because it's very hard to show that there's been negligence. It's not hard to show that there's asbestos in hospitals because almost all hospitals have got asbestos. What's hard to show is that your mesothelioma developed because of negligence with regard to that. But about half of these claims were successful. The other half were nonetheless people with mesothelioma who'd worked in the NHS. And remember, this understates the number of cases because, as we've seen from the previous presentation, not everyone makes a claim. The other thing about it was the rates of female death and claim with NHS staff are higher than male, which is an unusual pattern in mesothelioma statistics, but something that Steph was sort of alluding to in her presentation. And as we can see, the rate of claims is increasing. And one of the things that's sort of suggested in the literature is that there may be a third wave, what they're calling a third wave of deaths due to asbestos or of mesothelioma due to asbestos, where it started in mining, then moved into the sort of the industries where asbestos was manufactured and then used. And that we now may see a sort of peaking of mesothelioma in areas where asbestos is still present, such as schools, such as hospitals. Certainly the rates are not going down in the way that was predicted by the ONS a few years ago. They haven't given us the breakdown by occupation, so we don't know how many of these 961 were professional or ancillary staff. And we've requested that data, but been turned down so far. We're still kind of still asking that one. So that was one part of the study, but basically showed that there's probably a lot more mesothelioma around in the NHS, amongst NHS workers, than is suggested by the ONS data. We also, next slide, please. We also looked at the experiences of healthcare workers with mesothelioma. And in the literature, we only got, there's only data from healthcare professionals, and it's mainly from doctors, some from nurses, and a little bit from dentists. So there's no research that's looked at the experience of cleaners, porters, people working in the laundry and so on, where we suspect some of these cases are coming from. The lawyers know that that's where they're coming from, but there's no literature on that. And similarly, when we did our interviews, we actually only found nurses and doctors. We didn't manage to find anyone from any of the non-professional areas. What they suggested was the physical symptoms are pretty much the same. So things like pain, nausea, and breathlessness, as we saw in the first presentation. For some of the professionals, the meaning of these symptoms is different. Their awareness of what their significance is different, and in that sense, that there may be a stronger emotional reaction to those symptoms than others might have. So there tended to be quite strong emotional reactions to the diagnosis, exacerbated by those who did have knowledge of the condition. And actually, with that, a sort of a disappointment, or sometimes even an anger, that they had been working in healthcare and had been exposed to danger in those areas, a knowledge that that's probably where they got it from. There's a sort of loss of role that you see in doctors and nurses who suddenly become patients. It's very difficult for them. It's also difficult for their colleagues, and there were some examples of poor communication and poor care. And I do recommend that those of you who haven't looked at there's a YouTube video of Kieran Sweeney and his experience of care and the problems with communication, terrible communication sometimes, that he experienced as a doctor with mesothelioma. I do recommend that you have a look at that. So there's a lot more detail in our report. Next slide, please. We make a number of recommendations, and you can probably divide them into those sort of three categories. Some of them are to do with monitoring, sort of following other groups like Meso UK, and I think it's action on asbestos awareness, or awareness on asbestos awareness, but the idea of better monitoring. The current guidelines on monitoring are flawed and dated, really, and they're not in line with best practice in Europe. We're suggesting, so that's the sort of improved management. Also suggesting sort of education of management and staff as part of mandatory training. In terms of care, one of the problems that was noted was that people who were formerly healthcare professionals sometimes get treated as though they're still colleagues in their own care rather than as patients, and some of the way they were, the way they were given information could often be quite brutal. So again, we have a number of other recommendations, but I sort of just picked those out. I think that's my last slide. Is there one more? So, no more slides, so it's not going anywhere. Okay, so yeah, so obviously there's a big sort of thank you to all those who took part. It was I really enjoyed doing the interviews. The participants were great, but it's those were the sort of recommendations from our report, or some of them. Thank you.
Thank you. I should have said at the start that these studies are available if you wanted to read more about them. If you go to the Mesothelioma UK website, you can get access and get a bit more information. I appreciate that 7 or 8 minutes is not nearly long enough to present all this information. We are running a little bit behind, but we do have time for a few questions. At the end of the questions, we're going to take just 2 or 3 minutes to let folk readjust, go to the toilet, top up their tea or whatever, before the final session for today. But if we could perhaps move on to the questions that have come through, that would be grand. That's okay. So I have a couple here. Lorraine, could I put a couple of questions to you, please, first? Sorry.
Yes, certainly.
So you mentioned the digital platform, which is, going to be an amazing asset for patients and to gather information about patient experience kind of going forward. The question that's been asked is if there are any plans to include any in a section for carers or family experience.
Not as yet, but it is. I mean, this is very much in its infancy, and it could be. But whether that would dilute the findings, the whole reasoning for MesoDAX, as we're calling it at the moment, is to have this digital platform, as I say, where the patient is enrolled in clinic. Start off, that may be wherever they are on the disease trajectory, but hopefully going forward it would come from diagnosis. So the patients would be able to comment probably about a monthly or a 3 monthly gap to say about their treatment they were having, or how they were side effects they were having, and how they were being managed, and very much bringing that real world data of the burden of mesothelioma alongside the clinical management. So at the moment, it's we're lining that up and working on that for patients. Very much in its infancy, as I say, but at the moment it's for patients.
Yeah, and the other question we wanted to ask is, over what period of time, I mean, I know the answer to this, but I'll put it to you, over what period of time the Meso-More information was gathered. I think with the advent of the Scottish network, it would be good to know at what point in the network that information was gathered, so that perhaps as QPIs come in and things change, we could, you know, redo the survey and see hopefully what improvements have been made.
Exactly. It was from January to June in 2019 initially, and then we extended it to August to try and reach that 500 number, which we were aiming for, to have a really good cohort of patients. And 503 is an amazing number across the UK. It's taken us a while to get to the report. The report has been technically difficult to pull together. But what it does give us at Mesothelioma UK is the ability now to disseminate that information with every region, such as Scotland, every Cancer Alliance across England. So that's where we are at the moment. But obviously, we know now that it is a little bit of historical data. But nevertheless, I think because it has come from the patients themselves, it's very rich data to have.
There's a question in now for Peter, asking if healthcare workers are more likely to seek compensation, presumably than non-healthcare workers, and also, do you have an idea if healthcare workers are diagnosed at an earlier age?
So, sorry, can you repeat the first bit of that question?
Sure. So really what's been asked is if healthcare workers are more likely to seek compensation, and also whether in general healthcare workers are diagnosed at an earlier age.
Right, okay. The first bit of the question is, I mean, actually to both of those is probably I don't have enough, I don't have that sort of that data. However, I think it's unlikely that all healthcare workers are likely to seek compensation. There's certainly, even amongst the small numbers I interviewed, there were nurses who had gone to lawyers and been told that they didn't have a case. Mm-hmm. So it wouldn't even have got to the point of approaching NHS resolution. The legal process involves lawyers looking at your case and an insurance company deciding whether you've got a 50% or better than 50% chance of winning that case. Well, if you're a nurse who's worked in several different areas, actually pinning down one authority or one trust as being negligent in their management of asbestos is really quite hard to do. So I think I doubt that they're more likely to, because I think it's quite difficult to do. I would have thought you know, like my stepfather was a builder, and he, you know, when he developed mesothelioma, you know, everyone was onto him straight away. The lawyers were onto him straight away, and it was a very smooth path. I should think it's probably less likely amongst NHS workers. In terms of age, I'm not sure. I imagine they're older. the likelihood is that they've been exposed to smaller amounts of asbestos, and that this has manifested later in life. And that may be one of the reasons that the ONS data is so different to the data that we found through the Freedom of Information requests. That after the age of 75, they don't even record what job you had previously, so that all of that goes missing. But I would have thought they were probably on the older side, but I don't have the data to support that.
Okay. I do wonder if there's a sort of reluctance amongst some healthcare workers to seek compensation from the NHS just because they know there's a sort of, I don't know, a finite supply of money, and there's always that.
There was at least one person said that to me.
Yeah. There's clearly an awful lot of good work happening in Sheffield at the moment. I just wonder, Steph, are there plans for, is there anything recruiting at the moment? Is there anything, you've got a wide audience here that you could speak to if there's anything that you would like to sort of highlight?
Thank you. Yes, so we've got two sort of, well, one's more of a study and one's the prioritisation exercise. So the study that we're recruiting to at the moment is for one of our PhD students, Virginia Sherborne. I don't know if anybody knows of any patients who are ex-military. We're trying to interview carers, family members, friends of ex-military patients. So if anybody knows of anybody, please get in contact with Mesothelioma UK for more information. They've got all the information, so that would be fab. And the only other thing is that what I mentioned in the presentation, the research prioritisation exercise. I know the mesothelioma community is really enthusiastic, and everybody's always got so many ideas. It's such a shame we can't do these things in person at the moment. But if anybody does have any ideas that you think, this would be a great idea for patient care experience research, again, get in touch with Mesothelioma UK.
Thank you. Does anyone else want to add anything? Or
Can I just say, just alongside that, other research projects in the pipeline is looking at the difference the Mesothelioma UK makes to palliative care of patients, and what just actually, probably on a little bit of the back of Respect Meso, what does the mesothelioma nurse bring to the patient to make their care different? And also we very much like to move forward and look a little bit at peritoneal mesothelioma, because patients often come down, as we know, down a completely different pathway and are not directed to support. A little bit back to what Julie was saying this morning, the earlier part of the session is, where do they go for support? And so that's signposting to that, but on behalf of the nurses and the patients.
Peter, did you want to add something?
Yeah, I've got a request as well. I'm looking at teachers at the moment, or education workers. So again, it's the same thing. It's teachers, but also anyone who's worked in schools. So caretakers, cleaners, and so on. At the moment, we're not looking to recruit people to interview, but I am looking for articles that tell people's stories. So if anyone's, I'm struggling in the academic literature to find much that says anything about sort of education workers and their experience of mesothelioma. So if people know of sort of news articles or any other literature, kind of unofficial literature, that would be, I'd like to see that. That would be nice.
Brilliant. Thank you. And thank you again, all of you, for joining us today. I think we should probably stop there and just go for a quick break. And next up will be Dr. Beth Sage, who's Consultant Respiratory Physician at NHS Highland. Thank you very much for joining us today.
So, hello everyone, welcome back to the final session of the day. I always find this is often the most difficult session for everybody to stay awake for, although we were just commenting with the speakers that no one's got the excuse of trains to catch or flights to catch, no one's got to check out of a hotel. So I'm hoping that despite the fact we're running a little bit behind, you're all going to be able to stay and listen. We've got two excellent speakers this afternoon, and they are talking on the area on which I always am really interested at these meetings. I see patients and diagnose them with mesothelioma on a not infrequent basis. And one of the first questions is always, what treatments are there? What can you do for me? And so I'm always interested to hear of the new research coming up. As you probably know, we've not had many good news stories from clinical trials in recent years, but I think Professor Dean Fennell is going to talk to us about some really exciting results that we've had, and hopefully one of the newer therapies for mesothelioma coming on board soon. So I'm really interested in his talk today. Before I hand over to Dean, I would like to just thank our sponsors for this session, which is Digby Brown, and they've enabled us to have all of the AV support for this meeting, which has been fantastic from a speaker perspective particularly. So thank you very much to our sponsors. And I'm going to hand over now to Dean. Professor Dean Fennell is a professor in thoracic medical oncology, and he's director of the Leicester Mesothelioma Research Programme. And really what he doesn't know about mesothelioma clinical trials and research is probably not worth knowing. So I'm sure he's going to give us a very excellent talk this afternoon. Dean.
Am I unmuted? Is that okay? Good. You can hear me. Okay, great. Well, again, thanks very much indeed for the organisers for giving me this opportunity to speak. This is a special year for mesothelioma in terms of clinical trials. I'll try and explain why in the next few minutes. So what I'll do, actually, I'll divide the talk into these three sort of treatment settings. First encounter in terms of drug-based therapy for mesothelioma, the frontline setting, what we do to try and sustain control of the cancer actually following chemotherapy with maintenance, as there's new data there, and the relapsed mesothelioma setting, where there are developments afoot which are looking very encouraging. I'm going to start then in the frontline setting with this historic data. This is a summary of the clinical trials. I want to focus a lot on phase 3. We need phase 3 trials in order to change practice. These are large, often randomized studies in which we have a control arm which we're comparing our drugs to. And you can see here these 4 studies. The first is the definitive trial of chemotherapy. This was cisplatin pemetrexed versus cisplatin alone. And I want to show you this hazard ratio. This is 0.77. So this is a measure of the difference between these curves. If it's 1, they're completely overlapping. And as you approach to 0, these curves separate with a doubling of survival time if this is around 0.5. So as you can see here for this combination, a very similar combination, antifolate 0.76, and then the addition of this drug bevacizumab. This was never actually licensed. This is the MAPS-1 study from our French colleagues. And then this is really what I'm going to focus on here today. This is a historic study, FDA approved in only the last few weeks. And this is a combination of immunotherapy with an anti-CTLA-4 drug, ipilimumab, and nivolumab. This is a bold trial comparing combination immunotherapy against chemotherapy. And you can see actually numerically the hazard ratio 0.74 is better than all previous studies by a small margin, but nevertheless superior overall for this difference. So I'll just give a little bit of background around the potted history actually of the immunotherapy of mesothelioma. There have been studies that have focused really on the relapse setting with monotherapy. Many of you will be aware that pembrolizumab, Keynote 28, was perhaps the first and most prominent early study of immunotherapy. And then we have a number of other trials that I'll just point out. Lower down here, you'll see the phase 3, which I want to emphasize. The first actually was an anti-CTLA-4 trial. This was using tremelimumab versus placebo, and that was robustly negative. suggesting that at least in a relapse setting, single agent anti-CTLA-4 does not seem to have any activity. Similarly, actually, when looking at PD-L1 or PD-1 inhibition, this is the recent PROMISE study. Now, this wasn't against placebo as determined. This was actually against chemotherapy with either gemcitabine or vinorelbine. But essentially, immunotherapy versus chemotherapy showed no difference for PD-L1. So, not the most exciting, two negative studies really for single agents. Here in PROMISE, I think the control arm was the factor. Here, really, we didn't see any definitive activity for anti-CTLA-4. However, based on trials in phase 2 settings, single-arm studies, or in this case, with MAPS2, randomization of combined immunotherapy, combining these two classes, ipilimumab, nivolumab, and comparing that to nivolumab alone, there was a clear separation of the progression-free survival overall survival curve, suggesting that there was indeed synergy with those two drugs. So these two trials, INITIATE and MAPS2, really underpinned the Checkmate 743 study. And here we can see some of the data actually around survival. I'll just draw your attention here to the overall survival. INITIATE, they didn't even measure it. Patients going out to, I can't remember how many months, probably 20 odd months or so, didn't reach the median survival. MAPS2, we see a 15.9 month survival in the relapse setting, this is. And with Checkmate 743, we see 18.1 months. But I'll show you now sort of the key data. Before I do that, though, the response rate you can see in Checkmate 743, 40%, very similar to what was originally published back in 2003. And a respectable disease control. This is a combination of shrinkage and stabilization of the tumor at 76.6%. Now, this is the core result to draw your attention to. On the left here is the survival for patients with non-epithelioid mesothelioma. And you can see here a big difference between the curves, big space between the curves. And the hazard ratio for this was very, very impressive, actually, at 0.43, I believe, compared to the sort of epithelioid sort of subgroup, which of course is the majority of patients, where the hazard ratio was actually slightly, well, it was 1, or sort of close to 1. Now, what does this tell us? Well, it tells us actually that the immunotherapy is working approximately the same in the non-epithelioid and the epithelioid subgroups. If you see in this table here, 18.1 months overall survival for non-epithelioid, 18.7 for epithelioid, and the hazard ratio here is 0.93. So what we're saying is that this brown curve here and this brown curve here are indistinguishable. However, when we look at chemotherapy, we can see that in the non-epithelioid group, the survival is pretty appalling, actually, at 8.8 months. I think it's something we're all aware of when we treat patients with chemotherapy with non-epithelioid. It's not the best treatment for controlling this. But with the immunotherapy, we see 18.1. And when we compare the non-epithelioid to the epithelioid, chemotherapy is working so much better. And this hazard ratio, based on the histological differences, is 0.47. So this histology appears to be negatively prognostic. It's basically associated with a poor outcome in the control arm, whereas the experimental arm is doing okay, but it's not doing better because of non-epithelioid histology. Now, just showing you here actually the tail of the curve. This is encouraging. Many patients, you can see as circles here, haven't progressed yet, haven't died yet. And that probably means actually that as we go over time, this was an early read of data. It was a premature, immature data in the sense that the data was positive before time. But some of these patients who haven't progressed, if we wait perhaps for another year, we may see this curve move away, possibly even further from the control arm. So this is going to be very interesting. You can see here going out to 36 months, 3 years in non-epithelioid patients, a plateau of around about, well, almost 30%. These patients appear to be long-term survivors, certainly for non-epithelioid mesothelioma. It's the first time we've seen this in history, I think. So what about safety? Well, there's really, in summary, no major difference actually between the two groups. I have a serious treatment-related or treatment-emergent AEs, and we can see here 5% or less, slightly less for chemotherapy, but 5% for ipilimumab and nivolumab. So in general, a well-tolerated treatment. So I think if looking at the risk-benefit, we can see here in non-epithelioid, well, there's no question these patients are doing so much better with ipilimumab and nivolumab. In the epithelioid, there's a bit more equipoise, really. No significant difference in overall survival between chemotherapy and ipilimumab and nivolumab, and possibly just the faintest hint of a little bit more in the way of toxicity in that subgroup. I think it's really important to mention that this is an intention to treat analysis. The FDA gave their approval because the overall hazard ratio was 0.74, and that was for the total population. There wasn't a pre-planned stratification in the sense of separating out a group that was powered for better survival, let's say. So that's really why I think the FDA gave the approval, but I think the signal, as you can see, comes clearly from the non-epithelial mesothelioma subgroup. So what is driving this chemo resistance? Well, we've known for some time actually that sarcomatoid biphasic mesotheliomas do badly in general. This is with or without chemotherapy. They're more invasive, highly proliferative, and of course drug resistant. And one of the phenotypes that we've seen over the years with literature is that these non-epithelioid mesotheliomas exhibit features of what is known as epithelioid mesenchymal transition. This is a feature, very often stem-like feature, associated with all those characteristics that I described in sarcomatoid mesothelioma, particularly this invasive, highly proliferative, drug-resistant phenotype. And it is likely that with enrichment of EMT, as has been shown by Didier Jean in France and his colleagues using sequencing, gene expression analysis, this enrichment of the EMT signature in the non-epithelioid mesothelioma is a prime candidate for underpinning the drug resistance, I think, that we see in the Checkmate 743 trial. PD-L1, still very unclear, actually. I think the feeling from Checkmate 743 is slightly prognostic. And, you know, the trial initiates, it was clearly with 22C3 PD-L1 predictive from the single-arm study. Not so clear from the MAPS2 study. And if we look at the data from the Checkmate 743, we can see below here, PD-L1, less than 1%. Patients are doing a little bit better, going towards this line here. And patients with PD-L1 are doing a little bit better. And the reason they're doing better is predominantly because the survival in the chemotherapy arm is worse. You can see 13.3 months here compared to PD-L1 less than 1%, which is 16.5 months. So doing slightly worse if they have PD-L1. And we can see that the high PD-L1 maybe is a bit predictive. Maybe the survival is just a little bit better than low PD-L1, 18 months versus 17.3, but there's very little in it. So I would say that PD-L1 is acting here as a negative prognostic factor, not as a positive predictive factor as we see in lung cancer. So what next? Well, we're seeing a number of studies currently exploring chemoimmunotherapy. Perhaps the most prominent of those is the DREAM trial. This is actually looking at a schedule which has been successful in its scheme in lung cancer, which is combining standard chemotherapy with immunotherapy. Now, we've not seen a randomized trial yet, but two trials, the DREAM trial and the US PRECOG study, both have examined this combination. And indeed, the Australian team led by Anna Nowak published in Lancet Oncology only very recently on these results. We have the IN227 study from Canada, which is pembrolizumab combined with pemetrexed cisplatin. Now, this is a randomized trial compared with chemotherapy alone. And I would imagine we'll get a readout in 2021 for this, but a very important phase 3 trial that is similar in design to something called the Keynote 189 study, which led to an approval in non-small cell lung cancer in the frontline setting. Other trials, the Beat Meso study is of course being run at the moment in the UK. This is an important study because it's based on a very similar scheme as we saw in the Empower 150 trial in lung cancer, which again was positive and changed practice. Here we're looking at bevacizumab and chemotherapy, the MAPS-1 combination, combined with atezolizumab immunotherapy in the experimental arm, compared with this MAPS-1 triplet. This may well be a positive study. I think one of the questions we'll have to explore at a later date is whether or not, because this control arm is not licensed within the UK, what the cost effectiveness of that combination is going to be. But nevertheless, this quadruplet treatment could push survival out significantly. And I have to say, it's going to be the survival that ultimately dictates, I guess, where this treatment goes. But very exciting study. We've got a study. We completed it actually in February. It's an important study. There have never been any treatments which have improved survival in the relapse setting in mesothelioma. So we've looked at nivolumab, which actually happens to be licensed in Japan as a monotherapy. It's the only country in the world where that's licensed. The NHS, of course, is offering this currently until March of next year. But we've looked at this in a 2-to-1 randomized study against placebo, and we're presenting the data for this in ILSLC in January. What's next? How do you advance on Checkmate 743? It's a fantastic result. Well, we have to probably look to lung cancer to see what's down the road. I think this is almost in the post, actually. I can't imagine this not being another design that's coming soon. This is where chemotherapy, only 2 cycles, was given with ipilimumab, nivolumab, and showed a significant improvement over chemotherapy alone. Now, this combination actually has been FDA approved, and the chemotherapy is working as an immunomodulator. The DNA damage is triggering an inflammatory response through something called the STING-gas pathway, and that almost certainly seems to be priming the tumor actually to respond better to ipilimumab and nivolumab. And so this could well be something we see in mesothelioma in the near future. There is another study I want to draw attention to briefly, which is the ATOMIC trial. It takes a completely different approach, actually, and it's one I've spoken about a number of times before, and I'm sure you've heard about. This is a trial that is actually exploiting a vulnerability in mesothelioma due to a loss of an enzyme. And this vulnerability can be exploited using a drug called arginine deaminase. This is data from patients in the ADAM trial where there was a clear improvement in progression-free survival and indeed overall survival when patients received the arginine deaminase alone. These patients were selected on the basis of this biomarker. And this biomarker is predominantly in non-epithelioid mesothelioma. So by selecting these patients on histology, this phase 3, a global phase 3, that's really emerged from Peter Slotarek's work in London, will hopefully provide some evidence as to whether or not this can improve benefit of chemotherapy. So another approach for targeting non-epithelial. So let me very briefly move on to maintenance. There's been very little, active drug therapy for maintenance developed over the years. These are the slew of negative trials. We've got the flutamide, pemetrexed data here, FAK inhibitor study, COMMAND, which are all robustly negative. Just to remind you, the purpose of maintenance is to really try and control the cancer beyond chemotherapy. We normally give no more than 6 cycles of chemotherapy, and then it's really up to the biology to determine when that tumor comes back, because no drug is being given to suppress it. And having something after chemotherapy would be a good idea. Well, this fabulous study from the Dutch group, Navalt 19, looked at gemcitabine monotherapy randomized against best supportive care. And you can see here, I think, an incredible hazard ratio of 0.43 in favor of the gemcitabine. This was a phase 2 trial, not a phase 3, but I have a feeling based on these statistics, actually, and this distance between curves, that if this were expanded now into a larger study, we would see a positive phase 3. This also suggests, actually, that some form of active therapy the right active therapy after chemotherapy has the ability to more than double progression-free survival. We have a study where we're looking at dendritic cells. It's essentially an immunotherapy, but it's a vaccine-based therapy. This is now recruiting, and there's a trial in which we're taking cells out of the body. These are monocytes, which are differentiated into immature dendritic cells. These are then exposed to mesothelioma proteins, recombinant proteins, which then really program these cells to go back, when you put them back into the body, to seek out mesothelioma and orchestrate an immune response leading to inflammation. Based on some very promising early phase data, this is now a pivotal study that's taking place in these 5 countries, and this is funded by the EU Horizon 2020. So finally, to relapse mesothelioma, this has been the biggest challenge really, I think, to date, because we don't have a licensed treatment. These are unfortunately trials which have been very well designed, I think, but all negative. Here, determined against placebo, Vantage against placebo, practically overlapping curves. So what have we got? Well, as I mentioned, the confirmed trial is going to read out, hopefully, for January. And here we've got this 2-to-1 randomized trial against placebo. I think the goal here is to see whether or not, of course, we can improve overall survival and progression-free survival. But, one of the goals here also is to try and fully delineate what is driving response in patients. And as part of the study, actually, we do have an extensive pharmacogenomic analysis. And this is something that we hope we'll be able to try and accelerate and present data on soon after the final data is produced. There's no question that nivolumab as a single agent has activity, but the question here we're trying to address is that activity and its magnitude significantly better than nothing, which is the placebo. This is just illustrating the type of responses you can get with immunotherapy. Unfortunately, not in everybody. This is what we want to try and understand. This was a patient who had heavy thorax full of disease, and you can see here over 3 successive scans, pretty much clearing of the cancer. Another study that we're doing, which isn't the most perhaps exciting based on what else is out there, but can't be underestimated, is a randomized study of vinorelbine. Again, this result should be available very shortly. And what we're looking at here is the randomization, again, 2-to-1, vinorelbine versus active symptom control. We're looking at overall survival and progression-free survival. And here we are gaining additional data really around the potential biomarker, which we think will enrich for patients likely to benefit from vinorelbine. So I won't go into detail about that, but this will be available data, hopefully published in 2021, if not before. And finally, there's a trial which we opened, over a year ago now, about a year ago, called the Mesothelioma Stratified Therapy Study. There's no doubt that mesotheliomas are highly heterogeneous, and we need ways of partitioning mesothelioma into groups that are likely to benefit from treatment. So we've started this. It's rather crude sort of design based on the genetics, but this is a first attempt, I think, to see if we can pre-select patients based on their biology and then treat them accordingly. We've completed 2 of these studies. This is the rucaparib PARP study, which we presented at ASCO, and abemaciclib, which is a P16-4A targeted drug. And both of these trials, I think the rucaparib is in press. We should have the abemaciclib data to present next year. And these other trials, these are looking at novel immunotherapy combinations, but here the goal actually is to try and again use the clinical trials as a platform for understanding the genetics that underpin sensitivity to immunotherapy and all combinations. So with the PARP study, actually, we have reported this. This is a positive trial, it met its primary endpoint. There were responders, and as in order to try and understand what's driving this response, we've been using parallel models. So we're using explants. These are live bits of tissue which come from patients acquired at surgery. We can treat them with a drug like rucaparib. We can actually see activation of DNA repair mechanisms or cell death, and we can look at the heterogeneity, measuring quantitatively how they respond. And you can see non-responders here versus responders, where we can use gamma H2AX as marker to give us a signal of activity. What you can see is very satisfying because it actually shows big variation across the cohort of patients, and that's what we see in the clinic. So by sequencing these patients' tumours, we may be able to build a model of what's underpinning response. Here's an example. A patient here who had a response, you can see some dose response gradient, whereas this is completely flat, had a clonal BRCA2 mutation. So this was a ubiquitous mutation in the DNA repair gene BRCA2. And also this patient's tumour had something called signature 3, which is a feature of the genetic landscape consistent with a tumour that would be sensitive to PARP inhibitors. So this is a sort of thing we're trying to explore, but looking a little bit deeper across a broader range of tumours to see what mechanisms could be causing sensitivity. And this is finally just an example of a patient's response to rucaparib. Some patients stayed on treatment, actually, a fair proportion of the cohort over a year, having had relapse with prior treatments. And we have actually tried to rebiopsy areas of progression in order to be able to characterize differences in their genomic profile between that baseline and when this tumor has somehow escaped the effects of the drug as long ago, as I say, as a year later. So you can just see some shrinkage here of a tumor in one of the patients. So in summary, as I say, I'll repeat again, it's been a really amazing year actually for mesothelioma. Combination immunotherapy is now the standard of care. Officially, FDA has approved that. We won't hear from NICE until August of next year what the UK decision is going to be, but I would put money on it that non-epithelioids at least will benefit from this, if not everybody. The relapse setting is still a big challenge, actually. It might become a bigger challenge if 9LA type chemoimmunotherapy designs happen, because all the chemotherapy will be swept into the front line. But this is an opportunity, actually, for researchers, I think, to try and develop studies that can improve outcomes, but we're still lacking any positive trials. And finally, molecular stratification. Well, we've seen it work in other cancers. Mesothelioma, we're still trying to learn more about these mutations and how we can target them. But we know it's feasible. We know, trials like MIST and others that I'm sure are coming will allow us to hopefully get to more targeted, more effective treatments. And we heard earlier about Nick May with the PTCH driver mutation. I mean, that's possibly what's coming down the road if we can, identify these effective therapies. So with that, I'd like to thank you all for listening, and happy to take questions later. Thank you.
Dean, thank you very much. It's an excellent talk, and it does seem like we potentially have some new exciting treatments on the horizon for our patients. So there's been a few excellent questions coming through on the chat, but I'm going to save those until the Q&A session at the end, so please do keep those coming, and it saves me from thinking of them during Kevin's talk. So to move swiftly on, I'm going to hand over to Professor Kevin Blythe, who probably needs very little introduction to those who are working in Scottish mesothelioma. So Kevin has really been a pioneer for improving standard of care for patients with mesothelioma in Scotland, and has really worked phenomenally hard to get the Scottish Mesothelioma Network up and running. And I know it's been probably a labour of love over many years. But it seems like now he's got a new labour of love that he has to concentrate on for the next 5 years. So I'm going to hand over to Kevin, who's going to talk to us about Predict Meso, his international accelerator network.
Thanks very much, Beth. And hi, everyone, again. So I'm kind of quite excited to tell you about the accelerator. So it's been a program that we've been working up now for probably 2 years, and was funded by Cancer Research UK last year. And we kind of were about to, well, we did launch in March, but then the world changed, and it seems like everything has kind of slowed down a little bit, but we're working away in the background to get things off the ground. So I'm going to give a little bit of an introduction. You guys don't really need this background, but I think the points are worth making that, you know, meso in the UK is the lesser known epidemic, if you like. And for decades it has been underfunded. You know, we've really suffered relative to our other well-deserving cancers in terms of pounds spent on lives lost. And you know, Dean's talk is kind of inspiring because we start to see things actually changing. We start to see maybe 1 year survival starting to shift, but it remains a cancer of unmet need, and there is a kind of global epidemic on the horizon, because the images you see there are young children and adults working in the BRIC countries, so that's Brazil, Russia, India, China, where there is really no asbestos control, and so there is a kind of an epidemic looming. Dean's kind of talked us through the kind of exciting developments over the last 12 months, but really, you know, this is a review article published a few years ago that just looked at the numbers of trials active and what phase they were at, and you know, there's a positive trend there, which is a good thing. You've got more trials running, but you can see in terms of where those trials are that very few studies or very few research questions or drugs get to phase 3, and phase 3 is of course where we test whether a drug actually works better than what we currently do. And there are lots of reasons for that, but one of the reasons I think we would all agree is that we have not, over the last 20 years, understood the disease in a way that's allowed us to really design therapies in the best possible way. And therefore we're more likely to fail in patients. It's much better for us to fail in the lab before we go into a patient. You know, our understanding of the disease has improved incredibly, and you'll recognise some of the broad groups of drugs here: immune checkpoint blockers, and arginine deprivation were picked up by Dean. Viral therapy is probably not going to excite anyone at the moment, but you know, oncolytic viruses are another strategy that we've tested, and anti-angiogenesis drugs have certainly been a kind of significant flavour over the last few years, and antigen-based vaccines also. The difficulty has been translating our knowledge from the laboratory, or our knowledge about a mesothelioma tumour cell, into designing an effective drug. And so for those of you who are interested, there are these kind of important publications that have really allowed us to really describe the mesothelioma genome quite comprehensively now. And the figure that's plotted there in simple terms is the number of mutations per cancer cell by different cancers. And mesothelioma is the third one along on the left. So it's a cancer that doesn't actually have, relatively speaking, as many mutations as others. And in many ways, that's a good thing. And we would think that we could, if we could understand that mutation, we could drug that mutation and we could cure the patient. The real challenge in meso is that the mutations that occur are not mutations in oncogenes, and those are genes that drive a cancer's growth and life cycle. They are quite commonly mutations in what are called tumour suppressors. And tumour suppressors are a bit like the brake of your car. You know, not having a brake doesn't necessarily mean your car's going to accelerate. And so it's been difficult to understand how just not having the brake applied, not having a functional tumour suppressor, has translated into a cancer that kills patients so quickly. And it's therefore been quite difficult to design therapies. And we've extrapolated a lot from other cancers rather than had bespoke programs like Dean's. And the genome is also dominated by a very obvious inflammatory signature. Inflammation in the immune system seems important. So we really designed Predict Meso really from that position. And, you know, this scheme at the top that you'll recognise, it's a little smaller on my screen, but you might, I suspect you can get the idea, where we have usually 30, 40, thank you, 50 years of inflammation. And then at some point, we have the evolution of mesothelioma. And it's not clear what happens there. There is clearly a final critical last mile where maybe the immune system fails to stop killing those little tiny mutations that we all develop in our life, or some other inflammatory process develops, or something happens. And understanding that last mile gives us an opportunity to drug patients more effectively, but also perhaps to intervene earlier. And in the second little figure there, you've got a description of something called benign asbestos pleural effusion. So that is a phenomenon that the chest physicians here will recognise, where patients present with fluid and it looks like it could be meso. We biopsy them, but it's not meso, it's just inflammatory change or fibrosis. But we all follow those patients up because we know at some point they may develop meso. And there are some subtleties to that as to whether that was really a meso all along, but the reality is that that window of opportunity is that one that we can exploit, because we often have inflammatory biopsies in these patients just before they develop a meso. And that paired material is potentially incredibly powerful for us understanding what changes. And the other really exciting thing that's happened in the last 5 years, 3-4 years, is Marion McFarlane's lab in Leicester have a mouse model, which is kind of described by the little cartoon at the bottom. And in their mesothelioma mouse, if they inject asbestos into the pleural space, they can watch over time and they can actually demonstrate that some of the genetic features that we see in the clinic in established mesothelioma tumours are actually present in the pleural space before the cancer invades, or even before it becomes cancer. And so there is potentially this opportunity to intervene early, because some of these events are maybe obvious in patients before we see them. So the accelerator was funded last year and provides us with £5 million over 5 years from predominantly CRUK, but also CRUK's compatriots in Spain and Italy. And the aim and questions are reasonably simple in that our primary aim is actually to build these critical tissue cohorts of benign cases matched to mesotumor, and also to build technologies and infrastructure. And the infrastructure particularly includes really robust, well-designed preclinical models, so that we at the end of 5 years can get to a point where we have more drugs ready to go into a mesothelioma trial network, a bit like Dean's MIST platform. And we would really see these things as being running in series and together. And the questions that underpin that really are: how does inflammation evolve into meso? And what are the key molecular events? And importantly, what are the vulnerabilities associated with those events? Dean gave the really great example of arginine deprivation, which is a vulnerability in ASS1 mutated mesocells. And those are the sorts of things that we would be looking to see. And we also want to try and understand who might the best patients be to recruit to even chemoprophylaxis studies of high-risk asbestos-exposed patients. And so we need to understand risk, and we need to understand response, and I'll kind of talk you through that. So this is our map essentially of the network, and given the nature of the funders, we are predominantly based in the UK, Italy, and Spain, although we have collaborators in Belgium, and we have a significant collaboration in Brazil, in imaging, and that's important because Brazil, of course, are one of the big countries that are going to be faced with meso in the next few decades. And we've already had contact from groups in the US and other countries, and it is a network that we hope to grow and expand and share. And if you just look at the image in the center there, the network is a network in the sense that we aim to share everything, and that includes data and tissues and models and information. And it's also a network of work packages which are linked together. And so we have 5 work packages. And so in the time I've got, I'm just going to show you a single slide giving you a kind of brief overview of what each work package is going to try and do. So the first work package is the really critical step in actually building these cohorts of benign meso matched tissue pairs and using that tissue to understand downstream in the other packages how that meso has evolved, and also to build models using that tissue. There's a really important data sharing piece. Crispin Miller in Glasgow, who's our bioinformatics lead, is essentially building a sharing infrastructure, and we'll use ICGC Argo to share a lot of the sequencing and other data out with the network. We've placed a lot of importance on developing other new researchers. So we have a series of schools and seminars planned, and we have 5 PhD students who are spread across the countries, including 2 that are coming from Brazil. And the reason for that is it's for the sustainability of this and for this to grow, it's the people that will make it grow, much like our clinical network in Scotland. And so us developing these people, I think, will help us move the thing beyond the life of the actual accelerator award. The schematic there is just illustrates that the tissue collection effort is necessarily complex, in that we are collecting prospectively, and we'll do a large prospective study in the UK involving 25 centres, where we recruit patients with benign pleurisy and follow them up. And we also will have a retrospective element, which is going to be really housed within Mesobank, which is Robert Rintoul's labour of love. And Robert is going to build those tissue pairs for us in Cambridge. So the second work package is really our omics. And so the intent here is to use some really incredible researchers across Europe, Andrew Biancan in Glasgow, Susanna Cedrez in Barcelona, Manela Steller also in Barcelona, and Seth Kofelt in Glasgow, to help us understand what processes are allowing or driving the evolution of meso. And so those broad groups are the genome, so those are really the development of mutations in the DNA, the epigenome, which is more to do with the switching on and off of genes, and the transcriptome, which describes what proteins are expressed and whether those are actually active in the cell, and then the immunome, which is really describing the immune landscape around a mesothelioma tumour. And that's really critical in meso, because our pathologists constantly tell us that most of the biopsies that we send them are stroma, they are microenvironment. It's inflammatory cells, fibroblasts, and the odd tumour cell. And so we hope to try and understand that over the 5 years. So work packages 3 and 4 are together in this slide, and this is a hugely shameful simplification, but essentially the material that we generate from the patients will be used to generate preclinical models. And preclinical models essentially have various forms, but they can be as simple is the wrong word, but they can be as clean or as pure as a patient-derived cell line, where it's just tumour cells. That's harder than it sounds. or it can be an organoid or an organotypic model where we try and have a three-dimensional model that has tumour cells but also has some of these important immune cells. And then we have more integrated models that might be within a mouse, and particularly within a mouse with a functioning immune system, which again is quite complex and difficult to achieve. The thing that will help us is that Daniel Murphy, who's on this slide, has over the last 10 years perfected, well, no, developed, you wouldn't like me to say perfected, a genetically engineered mouse model that has got an intact immune system that develops mesothelioma in a way that we would recognise compared to the human disease. And it will really function in work package 4 as the test bed for new drug target combinations that emerge, that we can actually test them in that mouse before they go into patients. And then the final work package is split into 2 parts, and I mentioned risk at the start. So the risk element is the top little cartoon there with the orange boxes. And so it will be tied to the Meso-Origin, to the prospective tissue collection programme. And what we will be doing there is in all the patients who have benign pleurisy who we recruit, or a proportion depending on the biomarker, we'll collect biomarkers in blood and in exhale breath and in perfusion MRI, and then follow the patients up. And we hope to be able to conclude with a signature that actually identifies the really highest risk groups that you might use, for example, as eligibility criteria for a trial of a new drug that emerges from the back end of the pipeline. And then the last bit is the little cartoon at the bottom with the pink boxes, is we have a whole work package focused around artificial intelligence, and particularly its use in imaging. The images, could we just blow that slide up just a little bit, just to show so still not huge, but hopefully you can see the panel at the bottom shows essentially CT scans with green rings, and the rings are either axial or coronal views of mesothelioma, where the colours show the tumour that has been outlined. And that process is incredibly laborious for a human to do, but we've, over the last 2 or 3 years, worked with Canon to develop an artificial intelligence algorithm that we've trained to do that, so the green images you see there are actually have been drawn by an AI system that has never seen that tumour before. That you can't see it, but the image to the left is actually in red, is the human drawing that was used to train it. And so we're gonna, within Work Package 5, we'll pull together 1,000 CT scans from across the UK using the NCME network. So we're leveraging all their infrastructure. NCME is the National Centre for Intelligent Medical Imaging, and Fergus Gleeson runs that. And so that will allow us to hopefully generate an AI tool that could be used not just, it really is for clinical deployment or for making clinical trials cheaper, because you don't need a radiologist to report your response. Oh, there you go, fancy. Yeah, there you go. So that was it really. I'm going to kind of wrap up. I mean, some of these comments are not just about the accelerator, but are about, the clinical network. I think we have made a lot of progress. We've heard some challenging things, but we've also heard some really positive things. I think Dean's talk is incredibly exciting with what's on the horizon next year. And a big thank you to all those involved, including our audit staff, our QPI staff, our admin, and all the clinicians. The challenge really for Predict Meso and for research, I think more broadly, is better preclinical science and getting better drugs into trials. And the title of Paul Krause's book is really what we're trying to get to, which is surviving mesothelioma. And I think we're this year I think we're probably a little bit closer than we were last year for various reasons, even though the pandemic has been a bit miserable. And I'm going to stop there, and I'll happy to take any questions with Dean.
Kevin, thanks very much for an excellent talk. I think it's a really exciting project, really ambitious, and I'm impressed that you've even got it together and got funded. So congratulations on that. But I'm even more excited to hear the results in 5 years' time. So we'll book you in, I'm sure, for a repeat visit then, and you can update us on the results. We've had some excellent questions coming through on the chat. So if it's all right, I'm going to try and moderate some of those if people are happy to stay with us a bit longer. So Dean, a few really good questions for you, if that's all right, particularly around the chemotherapy. So from Sarah Morgan, what's your opinion of nivolumab now being available on the NHS for second-line treatment? And should we be doing PD-L1 more routinely in meso in the same way we do for lung cancer?
So I think the answer to the first question really is it's great. Having nivolumab as a less toxic second-line therapy is a good thing. There's no licensed treatment, so giving vinorelbine is off-label. If you give nivolumab, it's still off-label, but at least it's a licensed drug somewhere in the world, and that's Japan, and it's very well tolerated, of course. So the big question is, that's going to be something made available until March of next year by the NHS. Based on whatever we see in Confirm, we'll need to know whether or not NHS will be willing to continue to offer that if the trial reads out favourably. In terms of PD-L1, at the moment, the evidence suggests actually that it probably isn't a useful predictive biomarker. I think the big difference with lung cancer is that it is clearly a very good predictive biomarker. If you look at something like Study 24, which was just it actually led to frontline standard of care with pembrolizumab in high PD-L1, about 50% tumor proportion. We are not seeing anything like that yet in mesothelioma, where high PD-L1 selects for benefit. Confirm will be interesting because that placebo control arm is slightly different. We don't know what PD-L1 does in chemotherapy. It makes it work less well. But with the placebo control, we can get a clear idea of what the predictive and prognostic interactions are. And so that's something we will definitely present data on that in all 300 odd patients within that trial.
Great, thank you. And I think Kevin had a question for you, but I think you probably answered it during your talk, or at least the end is, what's your prediction on EMA and NICE and SMA approvals for first-line ipi/nivo for non-epithelioid? And I know from a clinical perspective, we're hoping it's going to be before August next year that we get access to this, but just wondering what your thoughts are on that.
Yeah, so I mean, the FDA had their first crack at the whip and they gave it across the board. As we know, the US is very different from many parts of the world where health economics plays a really important role. And particularly where in that subgroup setting, we're not seeing a difference between the epithelioid for the immunotherapy versus chemotherapy. It'll be interesting to see what NICE says. I would imagine actually that the non-epithelioid is a shoo-in, that's going to happen. It's got to happen based on the hazard ratio, but for epithelioid, it's still up in the air really as to whether they'll go with it. I thought the FDA would give it. I think the EMA may actually give it. I think there's a better chance perhaps than NICE, but who knows? I'd like to see patients having access to it, to be fair, either way. I mean, there's some patients with poor renal function, for example, who really should not be getting chemotherapy or can't.
Yeah, excellent, thank you. Question from Malcolm. Will, it looks like it's better to be diagnosed with a non-epithelioid disease. Maybe these patients could be considered for trials of surgery with either neoadjuvant or adjuvant chemo and immunotherapy. I don't know your thoughts on that.
Is that to myself or?
To you, Dean, yeah, sorry.
Yeah, so non-epithelioid in surgery is a controversial area, I think. Very invasive tumour, very proliferative, much shorter time to progression following surgery. It is true that if you give the immunotherapy, you might expect a longer time to progression. But, you know, the question then is around the ethics, I think, of having a radical surgical procedure being rescued by immunotherapy, if that makes sense.
Yeah.
So, yeah, it's a difficult problem. I mean, reducing the volume of the tumour and essentially creating a lower volume of residual disease might have benefits in itself. And so it may be a study that we see coming in the near future.
Excellent. And then I think we touched on this earlier in the afternoon, actually. So a question from Sarah Morgan, who's one of our colleagues in Wales. You know, you've got huge experience, Dean, in delivering clinical trials for mesothelioma, and obviously Kevin, you as well. But you know, much more from an oncology perspective. How can we reduce the barriers for our patients to get into clinical trials? So this is something that I know Kevin gets probably really bored of me saying. So I now live up in the far north of Scotland, having relocated from London, where it's very easy to get people engaged in clinical trials. And it's a constant frustration for us. And I'm sure for a lot of colleagues who live with more or who serve more remote and rural populations, it's not about the cost. It's not about the funding the travel. It's actually the burden that takes on the patients and their families if they've got a life-limiting malignancy. You know, the commitment that goes into a clinical trial with additional travel is really quite huge. So what do you think we should be doing, both from a clinical perspective, from a, you know, from the standpoint of the people who design the clinical trials and able to deliver it, as well as what we can do to support patients to engage with the trials that are on offer?
So I think the answer to that question is we need more phase 3s. You know, when you look at the sample size around a phase 2, you might be looking at 20, 30, 50 patients. And trying to deliver that through 30 centres doesn't make sense economically. With something like Confirm or Vim as an example, we're looking at 25, 30 centres. I still don't think that's enough. I mean, as you say, and actually I should mention this, that Mesothelioma in the UK played a really important role actually in providing funding for some patients to travel actually into that phase 3. You know, we tried with Confirm to involve all 4 parts of the United Kingdom. So I'm very pleased to say that Belfast was involved. We were able to get Northern Ireland on the map. Of course, Scotland were key actually to the study. But that's the only way. We need phase 3s. And that's the challenge, because of course you've got to have drugs that are active at phase 2 to get to the phase 3. So it means putting these drugs through these early phase trials, finding signals quickly that look as if they're going to be meaningful, and then rolling them out. I suppose the second thing is actually related to that, but it's attracting industry. They can do things pretty fast. And we see in lung cancer that actually the UK is not on the map very often when it comes to the big, you know, high impact international studies. Not always. Some studies, yes, but not as many as I'd like to see. And I think if we can get industry to be involved and work with us, then we'll have those rapid commercial, you know, geographically widespread studies available to all patients, hopefully.
I think one of the things I learned in COVID, and perhaps one of the positives that have come out of it, is really the speed with which a lot of clinical trials came up and running. Recovery, I think, is a phenomenal success story for clinical trials. The number of sites that were open and the speed with which that came on board, and it was able to react to results. And I realise that's a pandemic, and you're not going to be doing that with you know, non-emergent conditions. But I think, you know, from a trials perspective, I think we need to really think about how we deliver them more effectively for our patients. So I'm in full support of that as to what we can do moving forward. Don't worry, Kevin, I do have some questions for you.
No, I was actually gonna just jump in, because I think recovery is a really good example, because the thing that made, I mean, it's a pandemic, but the thing that made that possible, or one of the things that made it possible, is that you're using repurposed drugs largely. You're not using experimental medicines. And so we have woven that from the start into Predict, and that the drug screening that we would be doing on cell lines to candidate drug targets would be, primarily trying to use, if possible, FDA approved EMA. There is a list of many licensed therapies. And so if you can demonstrate activity from an antibiotic or hydroxychloroquine, God forbid, dexamethasone, you can deliver that trial at scale in any centre. You don't need a trials unit to deliver a very complex immunotherapy agent. So I think that analogy is a good one.
A question, Dean, for you. What routine sequencing do you think teams should now be doing and capturing irrespective of trial portfolio?
Yeah, it's a difficult one, that, actually, because we're doing sequencing within the trial context. Outside of trial, particularly those patients who have some form of legal compensation, I think it is helpful to get a kind of a profile of the molecular landscape. As papers like the MIS papers come out, with PARP, for example, there won't be any difference between vinorelbine, nivolumab, as from the earlier studies, and rucaparib. Actually, these are drugs that will have had a phase 2 trial attached to them with data that you may consider positive or negative. And the question then becomes, do you try to identify a biomarker to say that that drug is the likely drug for you to have? So we are seeing more BAP1 and P16, CDKN2A screening in standard molecular diagnostics. We're doing that now routinely. I think we're quite late to that game, actually. Andrew Nicholson in London has been doing that for quite a long time. But that alone, given that these are the big, low hanging fruit, BAP1, CDKN2A, these things may actually end up emerging in the diagnostic panel, allowing us to not have to think about sequencing. But I'll come back to, again, McMay, actually. The patch1 is a rare mutation, but it's an actionable mutation. We do see BRCA mutations, as we know, are clear indicators for sensitivity to PARP inhibitors. And I think that when an individual has the resource, or a centre has a project or something like that, if we can screen, like in Memorial Sloan Kettering in the US, what we'll have then is that opportunity to see these potential targets, and maybe have more McMays, actually, who we can offer bespoke treatments to. But I wouldn't advocate systematic NHS, NGS screening just yet. We don't know enough, I think, to justify that.
Excellent. So I think that's, unless there's any other questions coming through on the chat, I think that's covered. Unless I've missed any, please do put it in the chat box if I've missed you by mistake. But I think that's covered the questions on the chat. I know, Dean, they were mostly for you, but Kevin, I did have a couple of questions, if I may, very briefly before we finish off, and I hand back to you around the accelerator program. I think this is hugely interesting, as I've said before, but I'm particularly interested around the progression, or the potential progression, of the benign pleural disease into mesothelioma. We all know as clinicians it's there. Our clinics are not, we've all got our fair few patients who've presented in this way. How realistic is it, do you think, that you'll be able to predict when such a small percentage of patients progress to mesothelioma? How realistic do you think that's going to be? Are there any early signs of any early ideas as to what might be the triggers?
You mean the actual underlying science that affects that evolution? I think we don't know, because we don't have, in humans, we haven't seen those paired samples analysed at any scale. Marion McFarlane's lab that I kind of illustrated, they had shown hypermethylation of CDKN2A, which is the event in their model that then precedes the then evolution into meso. Whether that's driving or whether that's a passenger is kind of uncertain. I think there's it will take probably, we're going to recruit maybe 600 patients with benign pleurisy in the UK and follow those over 5 years, and we're only predicting an evolution in about 60%. And in reality, I think a large number of those evolutions are not evolutions at all. They're people who had a first biopsy that was negative, that had inflammatory tissue in it, and then a few months later they have a biopsy that shows cancer. So it's a slightly different nuance, but essentially it's still anatomically different and phenotypically different tissues that show a change. So I think it's a long answer to a question, to an answer. It's a long response, but I think the answer is we don't know what those events are. I think the theory is that it's a failure of immune surveillance in some form. But
great, thank you very much. Well, I don't think anything else has come through on the chat whilst we've been talking. So, oh no. I think one final message, which is really a message of support. So thanks, Kevin, for your talk. Amazing you were able to get the Predict Meso network study into Scotland. Sounds like an excellent project to involve Wales in as well. So I think if there's no other questions, that just leaves for me to thank Dean and Kevin again for really excellent talks, really informative and I think very exciting. And I'm going to hand back to Kevin, who I think is just going to tie up the meeting. And again, a big thanks to everyone who stayed on and listened, and apologies we've overrun slightly.
Thanks, Beth. Yeah, I hope people enjoyed that. The thing with these webinars, it's not like a conference where you can look out in the crowd and you can tell if anyone's still there. We could just be talking to ourselves. But I hope there are some people still there. I mean, I've really enjoyed today. I think there's lots to be excited about. Not least the fact that we had over 100 delegates signed up, and Meso is on the agenda, and it's something that is at the front of people's minds, and I think there's an infrastructure to support the patients and a way forward. And I think we've got a really fantastic network of researchers that can actually move forward some of these big questions, and I think you are seeing that in what Dean's presented. I think, you know, things are on the up, and I think we can look forward with a bit of hope as long as we get rid of the dreaded COVID. So just, I guess I do want to thank Elaine Smith and Anna Morton, who are our MDT coordinator and project manager, who've done a lot of the work in pulling this together. And I want to thank our sponsors for the meeting. So Thompson's and Digby Brown and Lockett and our AV colleagues. They've been fantastic. And I think I will just draw it to a close. Obviously, thanks go to Macmillan, Meso UK and Clydeside Action, who've funded the actual network. But I think we'll hopefully see you next year, and perhaps we can do it face to face. So goodbye.